One, start. Thank you.
Good evening, everybody. On the outset, let me wish all a very happy Independence Day. So it's 15th August today, and I welcome all the members of MOA, the executive members, as well as all the delegates to join for this MOA Masterclass. The MOA Masterclass was the brainchild of our president, Dr. Ajit Shinde, who has not been able to join. He has a parallel meeting going on regarding the IOA Con meeting, but he will be with us. And also Dr. Karne, our dynamic secretary of the Maharashtra Orthopaedic Association, is busy with that meeting. So on behalf of the MOA Executive Committee, our president and secretary, I welcome all of you for this MOA Masterclass on knee arthroplasty. We have 4 distinguished and elite speakers. We have Dr. Suryanarayan, we have Dr. Ashok Rajgopal sir, Dr. Harish Bhende, and Dr. Manuj Wadhwa. So we will start off with these, and I will introduce each one of them as we go on. We also have Dr. Sarang Devre from Aurangabad and Dr. Shiv Kumar Santapure as panelist for today's meeting. I take now great privilege in introducing to you the first speaker for today, who is none other than Dr. Suryanarayan. He needs no introduction, but I must say one thing about him which strikes me the most is his zeal and his enthusiasm and his fighting spirit. You know, all of us know that he underwent surgery in May 2017 in USA. And after that surgery, the comeback he has made and the fight he has put for that is fantastic, and all that is now history. That being said, he has been the past president of Indian Society of Hip and Knee Surgeons. He is also been has written many papers, chapters, has been at many conferences. He is currently the joint director at SIMS, which is the SRN Institute of Medical Sciences in Chennai. He has been the adjunct professor of orthopedics at the Tamil Nadu Dr. MGR University, and this honor was given to him in 2012. And more than anything, he is a fantastic person. So without further ado, let me present to you the doyen of hip and knee arthroplasty, Dr. Suryanarayan from Chennai. It's all yours, Dr. Suri.
Yeah. Thanks, Parag, for the very kind words.
So today, the topic which has been selected is a very, very interesting topic, and that is alignment conundrums. I think this is very important because there is a lot of confusion on these alignment issues. The constitutional alignment is good, whether the mechanical is good, the kinematic is good, or adjusted mechanical is good. So let us hear from the master himself, Dr. Suri, on his thoughts of this alignment issue. Dr. Suri.
Yeah. Thanks, Parag, for the very kind words. I think indeed it is just the love and the friendship we all share that keeps you alive and through all the adversities and to pep you up. How can I ever forget Professor Sancheti? What a motivation he has been from 1987, the first time I visited Sancheti Hospital in Pune with Dr. Ranawat at that time. So I think it's been a long, very pleasant road down the memory lane. And today's subject, revisiting alignment, I think there's always been a confusion, controversy. As we talk to the younger colleagues, they often say, no, I do the kinematic alignment, I do the anatomic alignment. But I think they're all bells of the same coin, some way or the other, how you hash it up. So I thought I'll just put in slightly simpler words, how to decoding the whole concept and so simplifying the alignment issues and the concepts. The question first comes, why, if one is successful, why do we need so many concepts in alignment? I think the reason being that satisfaction with the outcome of total knee is highly variable. We all know the papers, that magic number of 20% not so satisfied. The reason being that the mechanically aligned knees, which we normally, most of us do most of the time, aligns, it's a good long-term implant survivorship, but the function outcomes often fall short. So in terms of survival, they survive, they do well, but the functional outcomes often seem to fall short in certain significant percentage of cases, despite changes in implant geometry, implant design, the way we do it, and it has not changed much in the last 2 decades. Post-operative standing frontal X-rays, again, are of poor additive value in terms of predicting what is the load, in terms of how it works towards the eccentric lift-off and offsets and other issues. So that is the reason people have been toying with the idea whether the alignment issue should be approached in a different way, or should we alter the surgical concepts with the hope that they would improve the knee kinematics, with the hope that they would do the function. So in short, if you look at all the four, we are just going round and round, trying to change, modify, adjust certain concepts and techniques. Of course, there are one or two which are really sort of a paradigm change with this. So dissatisfaction in the total knee replacement is not towards aligning the knee, it's more towards a function. So whether can we have a normal, no pain, good range and good function endlessly for all the cases together? Unlike the hip, unfortunately, the knee is never a forgotten joint for a long, long time in most majority of the group of patients. And most discussions, we often focus on the bony sort of aspects, but equally important is the impact of all the changes that happens in the soft tissues and the ligaments. And whether this has any influence upon the various sort of alignment patterns which we talk about, whether they have some influence is a point I think one needs to debate. And if so, why? But this is an interesting thing which I have often once or twice before alluded to, was a treatise written somewhere in the Europe, how to maximize the functional envelope. This is sort of bracketing very clearly. Average daily activities, if you take, there is a band of what is called as a zone of homeostasis. In this zone of homeostasis, there is no pain, the swelling, warmth, range, nothing there. And then even scintigraphic evidence, if you look at the bone in the periarticular area, it is good. Then we have that sort of a buffer zone, what is called the zone for supranormal overload in a well muscular functioning athlete types who can do it. But suppose if you're going to jump from 10 floors, likely that you're going to have a structural damage. That is because it's a zone of structural failure. Similarly, osteoporotic patients down below, since they're not loading the joint, they don't have a great morphological architecture and they are suspect pain. And so we need to have a homeostatic situation where there is no swelling, warmth, pain, range, because any injury, anything is going to sort of aggravate this issue. What happens before and after total knee? I think we still have a deficiency in terms of what we get from this. There is still a load here or a scope for further improvement because we are not restoring this completely. Maybe because of the post-operative inflammation, maybe because the change in the kinematic points, maybe in the changes in the alignment or the muscle tone, whatever. Each individual point cannot be talked about. So in short, the short story is knee does not eliminate all the nociceptive sources of pain, which could be varied. And so there appears to be certain scope for improvement. We all look at the reduced tissue trauma surgery, sort of a MI type of approach, minimal dissection. But whether we are able to mimic the normal kinematics and whether we are appropriately able to spatially orientate the components as it was in the pre-arthritic phase. Unless we go back to that point and the pre-arthritic phase, probably all the ligaments are not going to come back to their own isometric points. And that is something which is quite an obvious thing which we talk about. The classic example is resurfacing. Whether it is a hip, the knee or the shoulder, if you're just going to resurface without doing any releases whatsoever, without sacrificing any ligament whatsoever, the results and outcomes are spectacular. Trying to be as close to the native patient morphology. And that's why the surface replacement of the hips have given very high performance athletes back to where they belong, and they're able to do the ultra marathons and other procedures. This was once said by an Iranian scholar that to design any prosthesis or a product for human use would have to aim to fit the product to the producer, because human body is a finished product. We can't change the human body, but the product has to get used to it. So unless customized, all replacements involve an element of compromise. So whatever the process is, they're all a sort of element to the best of the possibilities. I think we are compromising in this situation. So kinematic alignment, what mechanical alignment is always, today it's a dilemma. So long as the option was only one, we were very clear. We took the joint, we put 90-degree parallel cuts, and it was job done, and job well done in most situations, but for some percentage of sort of dissatisfaction in the patients. But the moment other aspects have come, it has, I think, thrown our heads into thinking into what is good. But I look at it as it's not a debate on one versus the other, that I don't believe in kinematic or I don't believe in mechanical, all that direction of discussion. But I think what we need to see is what is good in each of it and whether we can bundle up all the good things into one of our working processes or the working steps which we follow. And the discussion could dwell on what is the basis of choice, one over the other, if so, limits of indication for each of these and what are the limitations, And what guides the choice? I think it is more important than what is possible theoretically in the publications, in the paper, is how do I decide what I should do? It should be always based on familiarity, the feasibility of executing it, and a good sound understanding of the principle of the mechanics. Benefits and limitations should be clearly be visible to us, and the limits we should know. And at the same time, at the end of the day, even if you are trying one over the other, I think the proficiency with one backup as what I call the all-weather option should be excellent. And there is no question that is going to be the mechanical alignment of the joints. So take the good of each and then find what works best for us and try to adapt it to your sort of a working column. So this is just a picture. This is the constitutional alignment of a gentleman. I borrowed this slide here. And this shows the virus. It is something which we often see. There are people, but they have no symptoms whatsoever. So if you restore this patient into a straight axis, probably he's not going to be happy at all. Put him back to mechanical axis. Maybe, may not be, he may not be happy. It's just a point that is being thrown open. So we have three patterns in which we can have the patient alignment when we plan the total knee. Patient specific, where we don't touch and we bring back more or less nearly the same. The classical is the unicondylar, where we don't do, we try to undercorrect a bit and we give it back and nothing changes otherwise, both in the sagittal and the coronal axis. Or the kinematic concept techniques, which we'll come to a little later. These two attempt towards retaining the constitutional alignment of the patient. Then we have the systematic alignment, that the mechanical and the kinematic axis, which we'll talk about, which are said variations. And then the hybrid techniques of rightly going in between, that is the adjusted mechanical or the restricted kinematic axis. These are sort of trade-offs where you try to compromise in the extreme situations. So talking about anatomical alignment in the knee, this is nothing new. We have talked about it in the 80s. Hungerford propounded this. The aim is basically having a joint line which is in a bit of varus in the tibia to the mechanical axis of the limb. It's also called the systematic approach. The premise at that point in time was better load distribution with this, better patellar tracking, it helps, and there is a little less risk of lateral retinacular disease, overcoming the lateral pain, which is. The basis was on basically the anatomical divergence of the vertical axis. Almost we find the tibial joint line surface is not exactly 90, it is about 87 to 85 degrees. So this, when you correct it in the anatomic basis, when you put the foot flat from the heel strike, I think it becomes parallel to the ground, and the loading of the joint both on the medial and the lateral side seems to be appropriate. Thereby we eliminate the shear stress which is probably thrust upon the cartilage surface or the poly surface in these cases. So the anatomical alignment maintains essentially what is the good point about it, maintains the anatomic position of the joint line. But the big concern in that case was, in those times, was how to reproduce this 87, very tedious. It can well go 85 and become catastrophic. And at that time, the sort of success criteria for the joints was neutral alignment or 3 to 4 degrees of valgus, which Merrill Ritter sort of again emphasized over and over again. So the goal entirely with all the surgeons was to get a 90-degree sort of axis parallel to the mechanical neutral cuts, both in the distal femur and the upper tibia. So, but in the anatomic axis, they gave a slightly valgus alignment with the joint line with a better load. Today, is it possible to do that? Yes, to some extent, yes, because we have more precision tools available. You have industry, again, sort of supporting you with better manual instrumentation that can do this adjustment. It's not pure 90. And also some industry partners have gone the other way, giving you implants with an obliquity, sort of fill in more on the medial side and give you the same. So that is a mechanical alignment technique with the modifications on mimicking the kinematic approach. So, I mean, just one little example. This is a case in pure serendipity. I didn't know at that time any kinematic axis, all we knew, but all the times we were doing only about a mechanical axis correction. On one side, they did a uni, on the other side, she had a total. For some strange reason, it went into virus because it was balanced at that time. It's now 14 years down the line, she's good. Purely, it was not without any planning or pre-planning, it just happened. And I've been tracing some of these patients for a long time, how they are behaving. So it just goes to prove that only one complex relationship between the prosthetic alignment and the soft tissue tensions. It is one thing to get a no opening out or closing out on the medial lateral, but how tense are the ligaments, how comfortable they are through the arc of movement is probably the issue. Mechanical alignment, I think something we all do every day. I don't want to go much to it. The technique to recreate a neutral hip knee ankle axis placing the tibial and the femoral components in neutral alignment perpendicular to the mechanical axis. Classical mechanical alignment, we all know the prime contributors, Michael Freeman, Professor Insel, and Dr. Ranwat. I think Dr. Freeman was instrumental in getting the concept of perpendicular cuts and perpendicular parallel joint spaces equalized both in flexion and extension. It always sacrificed all the cruciates. So the components were perpendicular to the mechanical axis, but however, in most of the deformities, it required tissue release. Unlike the anatomic approach, where you decreased or minimized the need for the soft tissue release, in this, we oftentimes had the need to release a bit one way or the other. But the reproducibility, execution, instruments, universal adoption were all quite popular because it became very easy, standardized to execute. It was popular with most of the surgeons and eliminated all the dodgy elements of getting 87 or 85. You could get a clean cuts and it was success most of the time. That's why it has stayed today, even today, as the most popular technique. One thing about if you understand sort of mechanically what we do, it's tibia cut. Ideally, it's a tibia cut first. Tibia drives rest of the alignment and balance. So you first get the neutral cut and base all your flexion, balancing, extension balancing, everything over that base. So it's a neutral cut for all in the tibia. We do not pay any heed to the tibial morphological variants of various patients or the epiphyseal metaphyseal changes, which we see in some subgroups. So we sort of drive. And what we do in this case, I mean, one biggest advantage is in all these difficult situations, and this is the one stop. Nothing else is going to work. And it's the mechanical alignment that is going to work. So applicable across all morphologies and shapes. The mechanical alignment, I think, whether you do conventional navigation, patient-specific jigs or anything, one downside is it has no bearing on kinematics. All you want is a minimum parallel space, thickness enough for the prosthesis, both the distal femur and the upper tibia to satisfy without much of a stress. And the only impacts the loading pattern. The loading of the implant will be neutral, both on the medial and lateral. So basically, it is not a patient-specific alignment. It's a universal neutral alignment. Induces alterations to the tissue envelope, and it can impact changes in the isometry of the ligament attachments. Maybe, probably these things contribute to some element of dissatisfaction in some of these patients. But however, having said this, in terms of designing, manufacturing the implants also, it's a very biomechanically implant-friendly sort of a device. For example, in this case, for that matter, what happens is in this extreme deformity, you correct it, you have stumped it, but then it needs extensive release subsequently to correct it neutral. And then what you need to do is you need to find ways to reattach the tissues as much as possible. So at least you have some form of a static check train on the medial side so that the function gets not altered. So this will always be required in the mechanical alignment when you go on progressively towards more significant deformities. So the current positives so far as the mechanical alignment is concerned is implant designs support, especially the patella groove. I think this is very crucially to be said. The external rotation, which you drive their external rotation because of the neutral cut in the flexion, I think supports the patella. And I think most designs today are more patella friendly, whether you resurface or don't resurface. Even loading of the poly, I think the wear tissues has become much less. Eccentric load is far less unless it has not been done appropriately. All with the technique, like I mentioned, it's a good starting for people who are getting initiated with the total knees. And manual instrumentation today is very fine-tuned to ease the whole process much further. But when all these seem to be settled down, I think we got this, which came across as the neutral mechanical axis sacrosanct from the Mayo papers. That is, alignment can vary within 3 degrees, about plus or minus a valgus or a varus, without any impact upon the longevity. And so the loading patterns and the patient things seem to be working well. Only one caveat was that your balancing of the spaces has to be the maintaining the parallelism of all the sides, both in the flexion and the extension spaces. So this was a publication all of us know well at 15 years. What was concluded was mechanically aligned joints did not improve the survival rate. So if you have a 0, 90, 90 position, which we drive for, it's not that it's going to give you longer. Even a variance of about plus or minus either side is going to give you as good a result. So alignment alone is not a reason for the durability. This brought in the factor what is called the adjusted mechanical alignment. So what is adjusted mechanical alignment is nothing but an adaptation of the conventional mechanical alignment techniques with a sort of a room for you to undercorrect the constitutional frontal deformity, valgus or valgus, within about 3 degrees. Don't veer too much out of it. You may not get out of it, but I think safer to remain within the 3-degree sacrosanct number. Slight to moderate constitutional deformities sort of are preserved. So the earlier mild moderate deformities can be maintained or adjusted in this position. But the severe deformities, you can decrease it a bit, you can't correct it completely because they are beyond the range. So almost if you look at it esoterically, I think what you find, it is almost bringing the anatomic concept into the mechanical alignment and then bundling it up together. This is the adjusted mechanical axis. But now this is evidence-based because we got a 15-year data on this. So what we do basically is that when we adjust the coronal ML space balance between the bone cuts and the soft tissues. So by doing a 2 or 1 or 2 or 3 degree virus cut, what happens is you decrease the need for a medial tissue release and you're taken away from the bone dissection, or you minimize this. The release of trust and then release appropriately as the soft tissue demands. You may needle it, you may pie crust it, or you may probably generally release it completely, only the deep tibial ligament, and go ahead. So similarly, on the flexion side, the medial lateral space balancing can be done adjusting the rotation of the femoral component. You need not give a 3-degree total external, and based upon the position, you can do it by yourself. This is one example, just a class it was done with the image. This is a varus. What we are given here is a 2-degree varus. Now, because it gives you a dynamic flexion extension balancing numerical numbers, it's easy to support it, and you're able to get away without much of a soft tissue release whatsoever. So adjusted mechanical alignment technically is basically under correction of the frontal deformity, if necessary, in the varus valgus plane to a maximum of plus or minus 3 degrees. To a great extent, we hope that if that is sufficient without touching any soft tissues, we are able to maintain the mechanical femoral kinematic alignment. Fine-tune the tibial alignment to adjust it, both in the coronal and the joint line. So you're staying within the joint line variance. But most important, whatever you do is stay within the soft tissue envelope and titrate the balancing very, very carefully. You don't have to overdo or underdo this. So in short, I think the joint line, meniscus, ligaments all contribute to the isometric, their isometric attachment points determine the normal kinematics and function, no doubt about it. And all this is what we sacrifice. So alignment using the center of the femur mechanical axis has no bearing, like you mentioned, in the mechanical. So probably adjusted mechanical probably is a little bit superior, certainly gives you a little more freedom in terms of going towards the ideal kinematic situation. As these things were going on, I think there was the other debate which came in regarding the kinematic alignment. Steve Howell and others who felt probably to go entirely in another direction as an alternative philosophy for aligning. The goal was to restore all the kinematic axis, both the patellofemoral, sagittal, coronal axis, and in a sense, trying to just reposition the femoral and the tibial component exactly where they should be as compared to the pre-operative or pre-arthritic situation. So you try to come into a situation where it is pre-arthritic alignment, you have a model and then you fix it. So essentially resurfacing the knee joint like the resurfacing of the hip, and restore the pre-op joint orientation in all the 3 planes, not only the sagittal plane. So what you do basically is replacing the thickness of the eroded cartilage and the resected bone to accommodate the prosthetic thickness with the prosthetic thickness. You do no more, no less, give or take a millimeter or 2. So I won't go much into the concept of the kinematic or the anatomic alignment. Objective is to align the articular surfaces. So long as you know the axis to which it goes through, you are able to restore the pre-arthritic line and restore the parallelism and the perpendicular interrelationship among the kinematic axis. What ultimately you get, even when you do a dry bone, is in kinematic axis, it's more natural to the normal knee, but it is less neutral, unlike the regular knees which we perform. So be prepared for X-rays, which look a little odd, and you may probably think they are off position, but that's the way they are meant to be because of the basic morphology of their patients. It's a concept, and strangely enough, if you look at the kinematic concept, here comes a variance. It's a concept in slight variance to what we do. The X-rays, I'll be prepared to have an appearance of the X-rays like this and do not feel it. So probably the balancing. What is important is the balancing of the medial lateral side. The parallelism has to be maintained, both in extension and in flexion. And the steps to execute this, which may be slightly different. What we normally do is exactly what the advocates of an kinematic alignment advocate don't do. This is very strange, different. That's where the difference comes. Do not cut the femur perpendicular to the mechanical axis. Do not externally rotate the femoral component. Do not align to the epicondylar axis. Because when you do all this, it is their belief that kinematic alignment cannot be maintained because it is totally in variance to the needs or requirements of the kinematic alignment by interfering with the joint line obliquity and also the joint line height, both together concerned. So the changing thoughts and paradigms, if you are going in that direction of a kinematic axis or thinking in terms of this, is putting femur first. It is not the tibia that drives, unlike the mechanical alignment, is the femur that's going to drive your alignment. Restore and reproduce the nativity of the primary femoral component by exactly resecting just about that amount of bone, what is required to put in the component. And then subsequently, correspondingly accommodate the tibia into the femoral parallelism, restoring the joint line obliquity thereby. So I think that makes it very clear that you do the femur, you work on the femur first, create the native femur, pre-arthritic femur. That is the concept. How we do it is another issue. Correspondingly, then subsequently work on the tibia by giving an additional varus if necessary, a slope if need be, to accommodate the kinematic position so that without any tissue release, you're able to get in. This is what we do. You have to understand these under femoral sort of isometric points can be easily got. I think they are numerically have been worked out and defined. I won't go into it. Understand the axis by exactly cutting that amount of bone without rotating or without fixing. And suppose if there's an erosion on the condyle, about 3-4 millimeters in your planning, say then you cut only about 5 millimeters on the eroded side so that it is equal to the component thickness. So understand the design you use, whether it's 9, 9.5 or 10. I think you have to know what is the thickness of the prosthesis used. Cut that match the femoral component to the prepared articular surface. It exactly slots in like a glove. It goes inside. Bone cuts will always be equal to the component thickness, adjust for the wear, and these 3 steps will restore the kinematic position. So restoring the femur needs to be again individually planned based upon the damage, based upon the morphology, and defining the axis, cut thickness, always measure what you have done, and factor for the worn-out cartilage. Once you do this, you are more or less close to the ballpark where the femur should be. On the tibial side, when you need to adjust, I think this is a sort of a red flag. Match the native inclination. Sometimes the native inclination assessment may be skewed because of the erosion. So if it is 0, cut 0. If it is 3, you cut 3-degree varus. But if it is 5, cut only 3. I think the proponents go far beyond, but for an average person who is just trying to sort of baptize himself into this, it may be better off to not to veer anywhere beyond 3. Do not force any element of rotation. The posterior condylar cut is as it is going to be. So effectively what happens is that the 3D position of the femur is the prime driver of the knee function. And there could be some prone to alterations when you look finally at the mechanical axis. That's why I said, be familiar and be aware that your X-rays are not going to look very great because mechanical axis also can go 1 to 2 to 3 degrees inside. Normally, we compensate for the non-anatomic tibial cut by externally rotating 3 degrees in the femoral side, in the flexion. But here you don't do it. You let the tissue balance and tissue tension drive it so that we know how much to rotate. Rotate as much as it is required. And the subtle changes will happen, but this dissatisfaction probably may be helpful that we don't have to release anymore on either the medial, posteromedial, or the posterolateral side. So in the kinematic alignment, what are the keys basically is it's predominantly a bone procedure. Of course, it has its own lot of limitations. I'll come to it. Tissue releases are exceptional. Ideally, it should be exceptional. And this helps the implant position to be positioned very reliably. And probably that explains the good clinical outcomes in mild to moderate deformities. But having said that, let me quickly add, not all anatomies would be suitable to it, even though there are claims and counterclaims. Biomechanically inferior native pathoanatomy, basically a pathological anatomy of the femur itself, if it is inferior, they're not good for this. So kinematic, the concerns basically in this is, are we addressing the coronal issues? It's not, most of the thing is talking only about the sag issues. Addressing the sagittal plane issues, it addresses the coronal very well. It's very clear. But sag issues, when we have an 8-degree slope, what do we do? I think it is a thing we need to ponder, especially in this part of the world and in India. Most of us, we don't have a 3-degree or a neutral tibial slope. Quantifying the articular erosion in severe cases, how do we do? What do we do? I think unanswered. Where concerns, I think they have, Howell and others have published good results even at about a range of much more deformity, 5.5 to 7 degree of varus. But I think this is sort of a matter of concern, whether it will work consistently in everybody else's hands. Impact of ACL, PCL deficiency. How does it really help us in terms of the kinematics if the two major ligaments are gone? So I think it's a bit apprehensive in the extreme stages, but in the mild to moderate cases, maybe there is a justification. There could be a debate. The concerns and limitations is great degrees of freedom of deformity. The pre-existing patellofemoral issues and subluxations, how do we address? Severe valgus. I think there's not a problem with all this is not a problem with mechanical, but could be potentially a concern with the kinematic. One should be beware of this aspect of it. Another talk that came up was the adjusted kinematic alignment. Let me stop short saying that there are more questions than answers in this. And this is basically addressing more severe situations. And I think it's no point discussing unless we're very clear with the kinematic concept itself. So which way to go? I think there is no clear roadmap. In life, I think everything is a compromise. Blending best of both, there are some clear pointers to this, is restore the alignment orientation as close to the normal. So let it not be sacrosanct about the 0 degree cut, neutral cut. If we have to veer a little varus away into a little varus or a valgus so that we get a good balance without much of a tissue release, so be it. Try to combine the balancing with both a bit of bony cut and a bit of a soft tissue release. Putting femur first seems attractive because it helps us both in the extension and in the flexion side. And we have minimized the tissue release as much as possible, balance the gaps, like I mentioned, with a bone plan and preparation and limited tissue releases. Where does the technology stand at surgery in these cases? I think it probably helps, and it's basically a better enabler in finer plan and execution because you have numbers in front of you to work it. A numerical quantification of the balance is possible. That makes it that doesn't make it very difficult, in a sense that makes it easier for us to understand, to learn, to go and proceed. More importantly, the pre-cut assessment of balance through the range, along the not only at 0 and 90, but across the range of motion, I think is a very significantly added value tool, which probably will make it or minimize the other issues of mid-flexion issues. An independent alignment of the concept used. You can use whatever concept you want, and you can adjust and go ahead with this. Just a couple of examples. In this one or two, this was a varus. If you look at the tibial blaze page, there's a little bit in the valgus, but probably that corresponds to the femoral valgus, a little bit which you see in the distal femur. When you adjust it to that for the femur, when you do it without any release, I think you are able to get a good correction. And this is 1 month post-op. And then functionally, they tend to get restored. Not that you get this in all the cases, but basically just to enumerate the concept, what potentially it can probably add to us. Another of these cases, do not current beyond the permissible safe limits. I think there's the other one which I'm coming to. This was about 3 to veering towards a 4 probably. But if you look at the mechanical axis in the long scanogram, I think it's well within the range. Look at the other causes. Sometimes it could be, there are many reasons why you could have this. We have to probably put all this together and play between a sort of envelope which we create for ourselves, a safe zone, what I call, which we look for ourselves. This is the subsequent picture, and the person has been doing well subsequently. So improving functional outcomes, patient satisfaction is always the goal for all of us, whatever we use, whatever mechanical or the kinematic axis we use. In mild to moderate deformities, probably we can venture out a bit. No release, compensatory bone cuts, titrated balancing, and stay within the boundaries, I think is good. But if the pathology is very severe, and so what I call in this boxed area, the adjusted mechanical axis probably would be closer to the philosophy we are already following, which can work well. Severe pathologies, I think the classical neutral mechanical alignment is the way to go, no question about it. It's a no-brainer anyway. Our observation in all these cases has been that rotations, we don't tend to need a 3 degree sort of rotation. Often we find that they are almost at about 0 degrees. This is what we have learned looking at the numerical values which we see in front of our eyes as we correct this. Our focus at this time is fine-tune the balance with the cuts within 1 to 1.5 millimeters. Femoral rotation, we leave it to the free-floating tibia approach to verify functionally. And practically, we look at the balance to see. And invariably, it is often only about 0 degrees or 1 degree maybe. Tibial slope, we adjust as the need based upon, since we do more of a retaining devices, we look at the other functionality of also. And tibial inclination, we would never go beyond 3 degrees still. So these are all still work in progress. Work in what you are comfortable. Don't go on what has been discussed and taught. I think it is very, very important. Probably better to go one step at a time. Since 16, our current approach is we do the distal femur thickness equal, like I talked about, like the kinematic axis, take the thickness as the equal to the prosthesis adjusted for the erosion. Exceptions, of course, will be there: hyperextension, significant flexion deformities, or any special situations as the case may demand. Proximal tibia inclination and slope defined by the space. Component sizing is done, and the rotation is well compensated, again with the same posterior dissections. And we are able to sort of assess the kinematics pre and post-op, so that gives us sort of whether we are within the ballpark. So this is sort of the tool we use at this time. To talk about whether having me showing those examples with some technologies basically to easier enumeration, is technology a must? Certainly no. Certainly no. I think even the proponents of kinematic do without a technology. Understand the concept, assess the bone morphology, deformities, evaluate the correctability. Sometimes, more often, we also take the correction X-rays to get a better understanding. Always measure and go at every step. Every cut you take, I think the goniometer has to be there. You must measure it, at least in the initial 100, 200 cases. Use the contemporary instruments available to you because they give you much more freedom for corrections and adjustments. And do not be dogmatic. If something doesn't look good, go back to where you're best at or what you're best at. It is a paradigm change in concepts. The incremental benefit, it is still an open question. Whether it certainly improves the functional longevity or client satisfaction, do not know. But certainly, I think it's a road worth treading and trying to modify our own approach solely. So distal femur, proximal tibia, femoral rotations, all this can be done without even the machines. I think the instruments, once you understand the philosophy and the contemporary instruments are there with shims and other things, you can probably proceed with the same thing. In short, as I understand today, I think this has now been published. The kinematic concept in its purity is good for very mild to moderate cases, which is where it is the safest. In all the other situations, probably one needs to tread with a bit of a caution, understand it well before you sort of venture into other beyond. Some final, ultimately, the takeaways based on current evidence, mild to moderate, kinematic probably is workable, can work, or adjusted mechanical alignment is equally good. Deformities needing inclination of more than 5, tread with caution. I think I would not say don't do, tread with caution. If you're so confident and highly experienced surgeon would be able to do it. Use of aids or navigation, robot, whatever, they are enablers that help in widening the scope. I think nothing more than that you can well do without it. Manual technique needs understanding and incorporation step by step. Till then, classical mechanical is better. Like maybe start with just a femur, then go on the tibia, little bit varus, and then progress as comfortable as you are. The RTTS, minimal, no release, I think certainly seems to have an impact in terms of function and the post-operative pain relief. There's no question about it. Thank you very much. Thank you to the Maharashtra Orthopaedic Association for this very kind invite. I really enjoyed presenting this. Thank you.
Thank you. Thank you, Suri. That was an excellent talk, really wonderful. You covered the concepts really nicely. And as you mentioned, probably there are more questions than answers at the moment for this topic. You rightly said that. So I have a few questions to ask you now.
Sure.
And then we'll keep it open to panel and we can have some consensus, because this is a topic where there is, little bit of confusion, if I may use the word, because people, sometimes follow mechanical alignment, kinematic alignment. And to add to that, you spoke about adjusted mechanical alignment, and also you mentioned about adjusted kinematic alignment. So my question is, if that's the route you want to take, the adjusted mechanical alignment, how do you decide that adjustment? What are those factors which you take into consideration that, okay, this is the degree you need to adjust that mechanical alignment to, rather than going at 90 degrees?
Yeah.
So
yeah, pre-operatively look at the X-rays, study the X-rays. What is the epiphyseal, metaphyseal angles, or is there any metadiaphyseal issues in the joint? Look at the picture on the opposite side, if it is not deformed or if it's a bilateral situation. That broadly gives you what is going to be the orientation of the tibial joint line, what it is. And then similarly, we also do the distal femoral alignment axis, which is being marked and has been presented. Once you do this case on the table, when you expose, I think what we do is basically, if you want to change on only one side, trying to change on both the femur and the tibial side will mess it up. So you take the standard cuts on the femur, like here in this case, based upon the design we use, we cut that same 9 millimeter or 9.5 millimeters of the distal femur in the perpendicular to the axis. Once you cut to 99.5 millimeters of the femur you have cut, then that is given you roughly while you are on the femur, on the distal side. We then go on the tibial side. Once you go on the tibial side, then you see how it looks. So you can probably give a neutral cut. Before that, when you test the patient preoperatively with regard to the correctability of the deformity, that gives you an index whether you are going to need a significant release on the medial side. Let us take varus as example or not. For example, a hinged varus where you do not have any subluxation often tends to be a little more tight on the medial side during releases than one which subluxes. A subluxated one which is mobile and partially correctable, you may not need anything. In that case, probably I would go still neutral, cut it, and then go ahead and proceed. Release delivery being sure that it's not going to get any release. But it's a little tight, and if the X-ray has shown a bit of a varus, you may veer towards taking a degree or two more with the hope that probably that will loosen up. When you give the varus, also it helps in closing down or clamping up the lateral side. So your parallelism tends to get maintained a little better. When it comes to the flexion, you can, of course, once you've got this, you get the size and you can adjust the rotation based upon your sort of a spacer blocks. You can put it, or you can put the tensor and see how well you're able to open up and then adjust.
Okay. One more question. Is kinematic alignment or mechanical alignment, related to the prosthesis used? So is it true to say that a CR knee, probably you go for a kinematic alignment or a PSC, and after that, I would like also Dr. Ashok Raj.
I don't know whether I can do that.
So Suri, first, you can tell us whether a CR.
Yeah, probably CR lends itself better, but that it's not that it is sacrosanct that you have to have. CR lends itself much better to this because, like I said, we talk of kinematics and we don't preserve anything. What is the big idea of kinematic alignment? So at least you have got a posteriorly a force focus which is there behind. So I think it lends itself in a little better way, or probably it looks more convincing to that point in this case. It's not
Rajgopal, sir.
So first up, Parag, I want to compliment Suri. That was one of the best talks I've heard in a long time on a very, very confusing subject, because I don't think anybody really knows which way we are going, and we're adding all these adjusted sort of concepts to existing confusion. And I think Suri, your talk was absolutely outstanding. So the honest answer to your question, Parag, is I don't know. I think that's the honest answer. I don't think I know the answer to it, except to say that prosthesis does matter, whether it's multi-radius, single radius. I think that, and I think I'll try and bring that out in my talk on instability. Yes. What is actually an interesting concept is I was actually reading and preparing a talk on what is the current status of the various options that are available. And interestingly enough, the usage globally, and this is from the American Academy guidelines, the ARCUS 2020 meeting, where they did a survey, the incidence of the PS has gone down from 67% to 40%. The incidence of CR has gone down from 40% to 18%. And interestingly, the biggest rise in the usage of implants has been in the use of ultra-congruent and now very rapidly the medial congruent. So I think this is yet another dimension of insert stability, if you will. One of the things that we've done consistently over the years, Parag, is we have never ever used a 6 or 7 degree valgus distal cutting angle. I'm talking of a varus knee. We have at best used a 4 degrees. Most times our go-to is 3 degrees. And what we really shoot for is a neutral mechanical axis. So that is somewhere between the mechanical axis concept and the kinematic concept. For me, done manually, kinematic alignment is difficult because it's very hard to titrate that 3 degrees. So we still shoot for a 90 degrees. And in my own mind, I think the best concept that I have is the concept of the constitutional alignment that Johann Bellemans talks about, where we're actually cutting the tibia at right angles and incorporating the slope into the tibial insert. I think that by and large gives us the best the best kinematics, and this work has actually been corroborated by work done by Rick Comistak also, particularly with the BCS, that the overall alignment, the lift off on the lateral side during the swing phase is the minimum of all contemporary concepts in terms of the constitutional alignment and the journey type of an implant. So I think the go-to concept really would be the kinematic alignment in terms of we have now almost exclusively switched over to the medial pivot type of a design. That's what we are using most times now.
Okay, thank you. Harish, you are going to speak on this medial congruent knee later on, but at the moment, any concepts, any comments you want to make on Dr. Suri's talk or anything you
I think, yeah, excellent talk, Suri. There is no question. And he has illustrated all these various confusing terms of adjusted XYZ and restricted ABC and then primary. All those things are beautifully explained. If you realize there are so many different options, each of them proposed so vehemently by a group of surgeons, then it falls apart and somebody else say, okay, no, that is not the best, but a slight variation is better. Now, the bottom line, what I feel is not just what alignment you take. The bottom line is your overall alignment has to be within a normal range, plus minus 3 degrees of normal alignment. It shouldn't be too bad, the varus or valgus. But the most important part is the soft tissue balancing. All these alignments are sometimes is an adjustment done to get a better soft tissue balancing. And if you have a very good soft tissue balancing in the entire range, not just in flexion and extension, but in a three-dimensional thing, then you'll get the best outcome. The second part is we confuse these two things along with the type of implant. Do we want to have a particular implant which has got a fixed geometry like a medial pivot implant, or an implant which has got a a variable diameter implant? All these things, as far as they are close to the nature, close to the human body, they work very well. There is no a golden size of an implant or a type of an implant. The bottom line is get overall good vertical alignment and good excellent balance, and the patient should be happy.
Okay, thank you. We also take this opportunity to welcome Manuj Wadhwa. Manuj, welcome. Thanks for joining in. You have any quick comments? Then we go to Raj Gopal sir's talk.
So I think we start the next talk. It's more or less on the same lines. So wonderful summary, Dr. Suri.
Okay, perfect. So thank you, Suri. And just to let everybody know, he is a Bombay boy. He's just incidentally gone to Chennai. So he trained in Mumbai, and that's why he has a special affinity for Maharashtra and the Maharashtra Orthopaedic Association. Thank you, sir.
Yeah, just a small note, Parag, just to say,
please.
If I may, like what Ashok was saying about the incidence of the 2020 ARCUS survey, we started using the ultra congruent way back in 2000, when it was Aaron Hoffman, which brought, it was basically a surrogate design to bail you out when the PCL was gone. For 8, and then the whole world jumped around the deflection around 2009, like a hot potato. I dropped it after about 300 cases. And then we went on to the PS, then came back again now to the CR, and then the ultra congruent disappeared and then has come back in the last 7-8 years. But actually, I think, come to think of it, those days the discussion was the sort of the central rotation point used to be all over the place. Femorocentral interest, and it used to be all over when we studied it also. But functionally, honest, they have done extremely well. Right. Even though there was a little limitation, but with this better understanding how we put it, I'm sure you see also we should give us good results.
Dr. Suri, just one small word across. What is your feeling on kinematic implant versus kinematic alignment?
I have not used any of the implants, kinematic implant. Alignment, I think there are a few good points which can adopt to our regular workflow.
Okay. Great. With that, thank you very much, Suri. Indeed, an outstanding talk. So we now move on to the second talk, and it's my great privilege to introduce Dr. Ashok Rajgopal. He needs no introduction, but it's my duty to do that formality. He's the group chairman of the Institute of Musculoskeletal Disorders and Orthopedics at the Medanta Hospital in Gurgaon. He has been the past president of Indian Society of Hip and Knee Surgeons. He's the current president of Society of Knee Surgeons of India. Knee replacement is his passion, and he has really done that in a big way and has significantly influenced how that surgery is being done in India. He's an ardent follower of the CR knee. He was the first to perform the bilateral knee replacement in India and has a special interest in revisions as well as stiff knee, and has many publications in peer-reviewed journals in that topic. He's also a designer and has developed patented instruments for MIS totally, and also has many design patents to his credit. So let me not stand between you and Dr. Ashok. Rajgopal, the last point I want to make, he's also a Maharashtra boy. He's studied in Pune. For people who don't know, he's an FMCite and therefore has a special affinity for Maharashtra. So welcome Rajgopal sir. He's my role model and I always try to mimic him in whatever way I can. The floor is all yours, sir.
Thank you, Parag. That's a very, very kind introduction. Yes, I'm extremely proud to be a Maharashtra boy. My love for Pune is and Maharashtra is there for everyone to see. And thank you, Maharashtra Orthopaedic Association, for the very, very kind invitation. So Parag asked me to speak on instability in total knee replacement, what matters. And let me start by saying I actually have a passion for this particular topic. Instability is really a very gray area, much like what Suri spoke about, the alignment concept, again, a very gray area. And I'll just try and give you my understanding of this. I've been trying to grapple with trying to understand what instability means. How do you prevent it? How do you treat it? How do you diagnose it? And the next few slides is really a sort of an overview of my learnings over the years. So this is typically what happens with these patients. They're stable medial-laterally, but when you actually load these knees, they actually sublux. This, of course, is a gross example of absolutely radical instability. These are extremely easy to diagnose, but the real challenge comes in with the more subtle varieties of instability. And as we go along, we'll try and understand the presentations and how you diagnose, identify, and deal with it. So we all know that the outcomes of total knee arthroplasty, regardless of what alignment philosophy you subscribe to, are dictated really by only the three basic bone cuts. They are proximal tibia, which influences both the flexion and an extension. And the more tibia that you remove, the thicker is the height of your polyethylene and your tibial component consequently. Your distal femoral resection, which selectively influences the extension gap. So it stands to reason if your extension gap is larger, you end up with a recavatum and you need to distalize your femur. And then we have the posterior femoral resection, which is basically the femoral sizing option. This affects only your flexion space. And typically, when you have a flexion space that is larger than your extension space, you end up with getting what is called the posterior instability. So we do believe that it's a fair statement to say that AP stability depends on a balanced flexion and extension gap. And the gaps are really designed and dictated by femoral sizing and position, symmetry or asymmetry of your flexion space. I use the word flexion contractures and PCL release because these are two subjects that we see certainly in this part of the world very, very often. A lot of the surgeons who choose to use the CR type of a profile attempt to balance it by releasing the PCL. So that's a subject that we'll briefly dwell on. And I think one of the key criteria for stability when we do our surgeries is to check our stability not only in extension. Most knees are going to be stable in extension because of your posterior capsule and your collateral ligaments, but also in 30, 60, and now more recently in about 120 degrees of flexion, because that is the area where the subtle instabilities make their presence. It's also important that patients who have severe deformities of quads weakness, like neuromuscular disorders, foot status, planovalgus deformities, valgus deformities of the hip, these are all patients who need to be looked at and evaluated because these are the precursors of what may end up with subtle instabilities in the course of total knee arthroplasty. So again, when we look at the whole concept of the flexion space, the asymmetry, um, today maybe this line may be somewhat debatable, because some of the kinematic alignment folks do internally rotate the femoral component. Um, we subscribe to the mechanical axis, or at best the constitutional alignment concept, and we therefore use the transepicondylar axis and right side line. The point I would like to make is never use a single line if you're doing a manual, non-robotic, non-navigated knee. Use multiple axes, and as long as they all fall in line of what you believe is acceptable, you'll be in a safe space. The other point I like to make is whenever you correct a large deformity, be it a valgus deformity or a varus deformity, you need to understand what are the primary stabilizer, what is the extent of what soft tissues you can preserve or release to maintain flexion stability. And particularly in the concept of the valgus knee, you want to avoid a large posterolateral instability by dividing or releasing your popliteus tendon. Similarly, on the occasion of treating of severe varus deformity, try and be sequential, and the superficial medial collateral ligament must be preserved at all costs. I'll be a little provocative here and say that pie crusting of the medial collateral ligament, certainly in my book, does not exist. So neither does medial epicondylar osteotomy. I know I'm probably going to sort of open myself up to a soft belly here, but we have a very firm belief that medial collateral ligament is our primary stabilizer. The medial collateral ligament's integrity is critical to the stability of the knee, and any form of infringement of the MCL can lend itself to laxity. Similarly, the commonest reason for flexion instability is release of flexion contractures, and you need to evaluate the hip issues. And the biggest problem is anytime you are dealing with the flexion contracture greater than 20 or 30 degrees, balancing your flexion and extension gaps is a challenge. Resecting additional distal femur greater than 3 millimeters must be avoided at all costs. Use a posterior capsular release rather than doing additional bone cuts from the distal femur. And in these instances, you can choose your PCL issue by either releasing it or substituting it, or using one of the more modern type of options like the medial congruent. So suffice it to say that TKR stability is basically premised on component articular geometry and soft tissue support, and is probably better obtained biologically than prosthetically. As we go along, I'll explain this statement, because even constraint knees will not work if your collateral stability is challenged. Also, the fact that we probably don't recognize a lot of the patients who are dissatisfied. Instability after total knee is a common cause of failure of the unsatisfied patient, and accounts for 10 to 22% of all revision cases. And it's important to understand and identify the cause of the instability to avoid the same issues. So the early presenters will come with fusion, lack of confidence, particularly on stair descent. They often complain of giving way or buckling. And it's important that you identify and differentiate these from patients who have quads weakness and who are gaining stability by hyperextending. The gross ones, like the one you saw in that video, will actually complain of a clunk and something moving out. Those are very easy to diagnose, but it's the real subtle ones that cause all the problem. So this is our series that we have reported on, 1,647 that we reported on. And in this, you can see the instability accounts for almost about 22%. So the diagnosis is recurrent effusions, periretinacular tenderness. The most important subtle finding is difficulty in stair descent. And when you examine this under anesthesia, coronal plane instability and flexion will manifest itself. The point that you need to understand when you see these patients and evaluate their management is to exclude infection in all cases of instability. Instability may also be because of implant subsidence and loosening, but here the MCL is intact, and this is treated not by ligament reconstruction, but by restoration of bone loss. And varus valgus instability may be because of bone loss, wear, periprosthetic fractures. And again, the key issue really is your medial collateral ligament that will dictate the management of all issues of instability. I have done a fair amount of interaction with Johan Bellemans on this issue. We're currently working on a subject together. And he has really sort of put this issue of early instability and mid-flexion instability on a very firm path. And depending on the degree of flexion, the instability is noted early between 30 and 60 and mid-flexion at 90 and beyond. And he has written a lovely article in this book. So in flexion instability, the flexion space is obviously greater than extension space, and it is usually insufficient resection of the distal femur, undersized femoral component, a femoral component positioned in extension, or an excessive tibial slope. And if there is an insufficient posterior condylar offset, and one of the most critical issues that we have understood doing these knees for over years is restoration of the posterior condylar offset is the single most important anatomical variant that you need to restore for stability and good function. So PCL insufficiency will again cause, those of us who are CR surgeons have seen this often enough. You can have it either at the time of the index surgery or late instabilities. And when the PCL pops, you get this flexion instability. And to understand mid-flexion instability is a rotational instability, which is combined with external rotation and valgus in a knee flex between 45 and 90 degrees. And to my point, restoration of the post-PCO is the critical thing to restore your flexion space. And you need to understand this lines A and B between your prosthesis and the native femur. Excessive posterior tibial slope again will lead to flexion instability. To that extent, CR surgeons who use 5 to 7 degrees, you want to be a little cautious, and the word of caution here would be to try and reproduce the native anatomy of the tibia to be able to restore the posterior condylar offset and posterior stability. So the best way to prevent instability is prevent it. Correct your tibial slope, optimize your tibial axis rotation, get a correct coronal imbalance, look at stable flexion gap, increase in AP femoral dimension. Over the years, one thing we have sort of stuck with is we do all of our primary knees like we do our revisions, which means we stabilize the flexion gap and then translate that into extension. And you ensure medial lateral stability through the arc of movement. And this was also done by instructional course lectures by Kelly Wentz and Matt Abdul. You want to avoid elevation of the joint line and the contentious topic. A lot of authors believe that joint lines are not relevant to us. It is critically important. Multiradius is again something that lends itself to instability. And of course, the medial collateral laxity to avoid mid-flexion instability. So the main factors are attenuation of the medial collateral ligament, and I cannot overemphasize releasing the anterior fibers of the MCL, which is what you do when you pie crust. I'd be happy to sort of get into discussion on this subject, but for us, this is a dogma, not to pie crust or not to do a medial epicondylar osteotomy. And malpositioning in any axis, whether it's the transepicondylar axis, will lead to non-isometric collateral ligaments. And finally, when you look at the posterior, the PS type of design, the Campos box geometry, you need to have a robust design to ensure good stability. So flexion instability will happen in both CR and PS knees. Interestingly, in CR knees, it happens in very well aligned and well fixed knees, usually because of disruption or over-release of the MCL. And the typical symptoms are patients are doing well. Suddenly they complain of pain. They have this feeling of instability. Sometimes it is subtle. They've been having difficulty in climbing downstairs. And then they complain of inability to extend the knee or dislocate their knee. In the PS knee, on the other hand, it's usually caused by a loose flexion gap, a large polyethylene with collateral laxity, typically seen in valgus or flexion contractures, or in very aggressive post-operative rehabilitation. And dislocation is rare, less than 0.5%. And again, to be provocative, what I would say is any patient who flexes very rapidly and at about 2 months or 2.5, 3 months has 140 or 145 degrees of flexion, that patient is flexion unstable. And to my point, the June edition, or I think the May edition of Journal of Arthroplasty, again, an article by Doug Dennis and Rick Comistak has actually alluded to this fact using fluoroscopic studies, hyperflex knees, high flex knees usually have an element of flexion instability. So examples of symmetric instability and asymmetric instability and some extension instability. So these come in various dimensions, both in flexion, extension. So the symmetric flexion instability is usually because of excessive slope or undersized femur, attenuated PCL. Asymmetric because of errors in femoral rotation, collateral imbalance, and tight PCL. And this really will cause a femoral lift-off, as you can see in this case. So downsizing your femur, which used to be advocated at one point of time to gain extra flexion, will definitely get you more flexion, but at the cost of increasing the flexion by 12 degrees by 2 millimeter downsizing the femur. But it also opens up to a flexion instability by reducing the stability that is compromised because of reduction of the posterior contour offset. Again, 1 degree increase in the posterior slope will increase your flexion by 2.2 degrees, but increase your laxity by 0.6 millimeters. So to my point, sometimes it's better to err on the side of getting a functional range of flexion in the range of about 115, 120. And I think there are enough authors and enough very peer-reviewed articles where the functional status of weight-bearing flexion, deep bends, has rarely gone beyond 117 degrees. So in newer designs, this was done by, like in the high flex designs, cutting more posterior condyle. So the posterior condyle became thicker, the cam and post was redesigned, mobile bearing was used to accommodate, and pretty much we have understood that all of these were possibly only making the design more safe and preventing digging in of the epicondyle. So in terms of management, again, great advocate of this, Jan, using a larger femoral component in case there was a combined AP and a varus valgus instability, using a thicker poly, flexing the femur up to a maximum of 5 degrees and increasing constraint if these did not work. And if there's only AP instability, you decrease the tibial slope, take a stem or an offset stem and align your tibial base plate, or switch to a PS or a what is now available as a mid-level constraint, the MLS option in some of the designs. And finally, if you have consistent instability in spite of everything that you're using with your primary, you go to constraint design or whatever description, or a linked hinge. Typically, these designs that were described way back historically by Crack and Krakow by ligamentous advancements have really not stood the test of time and now are purely historical. So our philosophy really has been to use the least amount of constraint. We use non-linked options, and we believe it'll solve most of our soft tissue failure issues as long as our MCL is intact. And to the point that no constraint is going to help if malalignment or laxity of ligaments ensures. And this is a classic example of 2 cases that we revised. They came to us in this state, they had been revised earlier. And despite the fact that both of these patients had constrained options, the knees dislocated primarily because there was no collateral or capsular stability. Another example that we treated a long time ago, disorganized knee with posterior instability, again had no collaterals, and we treated this using a RHK. This was way back in the late 99, I think it was. It was almost 20 years out. This is a very interesting patient who had a failed is MCL, LCL, and ACL reconstruction, had a total knee replacement. The MCL failed again, so underwent a second revision, but again had gross instability because the collaterals were insufficient and ended up with a rotating hinge. Patient with a classical, this is the same patient whose video you saw earlier, a gross instability. You can see the difference between the flexion and the extension gap of almost about 5 centimeters. And again, this was treated by a block to elevate the joint line, use of the stems, and it restored good alignment. And this patient is doing well about 15 years post-op. So we published this in JOA, whether the flexion instability outcomes are any different to those of others. So we looked at aseptic losing flexion and infection revision cohorts, and the improvement in the instability cohort was really the lowest, primarily because these were well-functioning knees or hyper-functioning knees preoperatively, so the improvement was less. And in terms of the preoperative scores, when you look at the functional scores, the WOMAC, again, the recovery in terms of the range was comparable in all the three groups. When we looked at the patient-related outcomes, there was a higher percentage of poorer outcomes in infection as compared to the flexion and stability group. The highest and the best outcomes were in the aseptic loosening revision cohort. So in conclusion, patients with flexion and stability had less improvement in the MKSs in WOMAC. Flexion and stability had the lowest proportion of good outcomes, largely because of the relevant high preoperative scores, and a larger cohort is something that we're working on, and we'll be able to publish this at a later point of time to be able to validate long-term survival. This is our article that we published in the journal in 2017. So currently, this is our algorithm. Primary knee, we look at instability in terms of bone loss and instability. Bone loss you can address in one of many ways. Instability, we look at the MCL integrity. And if it is intact, you can use a CR or a PS. And now MLS, if it's not there, we use a TC3 or LCCK. And if these are compromised and there's gross instability, we use a rotating hinge type of an option. So the goals are to restore alignment, create symmetric flexion extension gaps. And sometimes here, the role of intramedullary offset stems is very, very helpful. Trial components are the key ingredients for our surgical tools. They work as trials and spacers, optimize exposure, minimize mode resection, the three-step reconstruction, and the least constrained articulation. Thank you all for your attention.
Thank you, sir. Thank you so much. That was an excellent talk on instability. A lot of doubts, a lot of concepts have been now clarified. I can speak for myself, my understanding has drastically improved after this talk of yours. So thank you, sir. So we will have some questions now and then comments from our other speakers too. So let me set the ball rolling, sir. The first question I want to ask you is, you gave a lot of emphasis and importance on the MCL, over release, and talked about that. Many times while doing a severe varus knees, and it has happened in my hands also, we have over released it, and then it at that time that you have over released the MCL. And once that happens, you try to just sleep over it, you just maybe suture it and you leave it. But what exactly are the steps one should follow after knowing on table that the MCL has been over released? What should be done?
So great question, Parag. I think we've all been through this step. So we did everything that everyone does. We tried suturing it. We went from a CR to a PS. And then we realized that if your articular height is going from, say, 10 to 12 to 14 to 17, and that height is progressively increasing, I think that is the first red flag sign that knee is going to fail, regardless of what kind of sutures you do. If it is an avulsion from the condyle, those are relatively easier. You can put in a suture, or you can put in a suture anchor or a screw or a washer or whatever, and immobilize these as mediolateral sort of stabilizers. They will usually do quite well. Mid-substance tears are the ones that are really bad. And if you're going into progressively high, you take a 14 and that it accepts a 14, and then 17 is also available. So in extension, you're good. But as you keep flexing, it starts to open up. I think that's really the time to sort of change the ship and go on to a more constrained option. I would try with a mid-level constraint. We have started using this. In a lot of times, these bail us out quite well. But if it's a complete transection, I personally would go to an LCCK, and they will give stability. But my only sort of a warning sign is if the postural medial corner is gone, and you can actually put your finger in at the back, and as you flex, you put it around the medial condyle of your implant, and you can feel a gap at the back of the posterior medial corner. That is, for me, is an indication that even your LCCK will fail, similar to what we showed you. And possibly those would be the indications of intraoperatively switching over and maybe even going up to a hinge.
Okay, excellent. So I think the answer is that don't hesitate to change your joint, what you're using, because the cuts have already been made.
Yeah.
But it's never too late to go that way, because those patients are going to come back to you. And I think it's a bold decision you have to make, but you have to make it so as to save you of further agonies in the period to come. I think my second question is regarding this posterior condyle offset. You also gave that a lot of importance, and you showed in one of your slides, how to measure it. But in reality, and I can talk for myself, we never really pay attention during the surgery on this. Whatever is the offset is restored. You take the cut and it gets restored, and it's not that you're aiming for that. Most of the times you get it right. But have you now changed your steps in any way so as to predict the posterior condyle offset which you need and do those steps in that particular way?
So again, great question, Parag. We have started making a bit of a big deal about sizing our femoral component, because your flexion stability is really a size issue, and your extension stability is your position issue. So now, I've been using almost exclusively the Persona system. So with the Persona, with the 2 millimeter increments that we have, we are able to very accurately position the size. And you're rarely between sizes now, because you have the option of narrow and standard as well. So you pretty much get it. The point I would like to make is always remove your posterior condylar osteophytes, not only on the medial side, but also on the lateral side, increasingly, particularly the kind of knees that you spoke about, the really severe deformed knees. Even for a varus knee, sometimes there will be a posterior osteophyte on the lateral side. So you take a little bit of trouble and try and remove that, size it. If at all you're between sizes, I will upsize it, and then I will go to doing a, as I said, over the last about 2 months, we have gone almost exclusively to using medial congruent designs. Right. But that's my go-to option.
Okay, fantastic. So any questions from the other panelists or any comments, Manuj?
So it's always a pleasure listening to you, Dr. Rajgopal. Now, as we all, I think, sharing the inputs for the youngsters listening out here on the CR knees, I would have 2 things in mind. Dr. Rajgopal, first, for people who have started doing CR knees, of course, they are not using the medial pivot knee, it is the other CR knees. What is the percentage of cases where you think they should be keeping an ultra-congruent insert with them?
So, ultra-congruent is a great go-to design, because it takes away the stress of whether you have retained your cruciate or not. And if you're using a design where ultra-congruent is available, I would say keep it. If there is any hesitation in your mind on the viability or intactness of your PCL, just go ahead and use the ultra-congruent. There's just one point that I want to mention. Certain companies actually mandate that when you're using an ultra-congruent design, you actually have to remove the PCL. You excise the entire PCL and empty out the intercondylar notch. There are other companies that don't. So you need to be very clear in your mind, whichever company you're using. For instance, in a Zimmer situation, when we use Persona Ultra Congruent, we actually have to empty out the intercondylar notch. Whereas if you are using the some of the other designs, for instance, the Smith & Nephew, you don't actually have, you can use a lipped version, keeping the vestigial or the PCL intact. So just be mandate that you are comfortable with what type of a design you're doing. And it's a great go-to option, because then you're not really stressed out about your PCL and so on. If you are using the PCL, one thing retaining design, the intercondylar notch and the posterior condyles must be bereft of all the osteophytes. Very often, we remove the posterior osteophytes, and the intercondylar notch, particularly at the back, is all closed out, and that stresses out your PCL. So you want to take one of these narrow osteotomes and just go along the medial and lateral boundaries of the intercondylar notch and remove those osteophytes. And it's surprising how large osteophytes are actually tucked away at the back. So you need to take that. But as a beginner, if I was a CR surgeon, I would keep it 100 times out of 100, because it gives me the stability that in case I'm not able to balance my PCL, I can just go back to a UC.
Dr. Rajgopal, my second question goes in as to prevent the late failure in the CR knees. What are the tips people should do to prevent late rupture of PCL? What are the intraoperative steps we can do so that subsequently we do not have a late rupture of PCL, which is one of the big complications we feel across?
Yeah. So again, great question, Manuj. The first thing is, do not stick to a dogma of 5-7 degrees of posterior slope. I think reproduce the anatomical slope. And I think anything about 3 to 5 would be my upper limits. I mean, you've done enough knees and you'll sort of validate the statement. Sometimes the posterior slope is as much as 11-12 degrees, and you do not want to reproduce those. So even in those type of situations, you want to go back to about 5, maybe 6 degrees, and sort of get that balance right. That also comes back to my point of the posterior contour offset, because that helps to position your tibia under the femur or femur on top of the tibia. Balance your PCL, and whatever you do the polo test. Make sure that that Dick Scott described, and deep flexion, your anterior part of the tile should not be lifting off. And as long as you can do that, and if you are trying to release it, then the point that you mentioned earlier, just keep a ultra-congruent design available. Just use it. It gets you out of a lot of sleepless nights.
Great. Thanks, Manoj, for those excellent questions. Any comments, Harish? Any questions? Then Suri.
Just one question. If you are doing a CR knee, I don't have experience of doing any single CR knee because I don't do CR knees. So, Ashok, if you are doing a CR knee, and I mean, not you, any junior person, and if you find that, okay, my PCL, that balance is not so well, I have to have some more stability. So should you do a clearance of the box and use ultra congruent, or go for a posterior stabilized knee? Which is a better option?
Harish, for me, it would be the second. I would go to a ultra congruent. I'd clear the intercondylar notch and stabilize it using an ultra congruent. That's the easy way out, because then for guys like me, I don't feel that I've cheated. I've not sinned. I can still have my beer in the evening without having the guilt feeling. But you can do either or. I mean, again, it depends on your philosophy. If you're not comfortable, like I was saying, this WOS thing, it's a wonderful. I would sort of urge everybody to read it. More and more people are coming around to the concept that whatever you do, the results are exactly the same. CR and PS, cemented, uncemented, rotating hinge, rotating platforms, fixed platforms, patellar, no patellar. The results are almost identical. And so at the end of it, I don't know why we get into these debates and so on. I think millions of hours and minutes have been spent debating this. At the end of it, like Suri pointed out, as long as you understand the ethos and the philosophy of what you believe in, and you're able to achieve it. I mean, the point that there was this beautiful slide that he showed, of the various aligned tibia at 14 years. I mean, it looks pristine. And again, there's this article where well-aligned knees actually do much better than well-aligned knees. I think this is a very, he says, landmark article. So I don't know where we are going, and I think we need to do what we believe in, what comes naturally to us. CR is good, PS is good, ultracongruent is good, medial congruent is good. As long as you can balance your knees, get your flexion and extension gaps stable through 0 to 110, 120, I don't think it really matters whether you do one or the other.
Fantastic. Thanks, Harish, for that question. We go now to Suri. Any comments or questions?
Yeah, I think just following up with Dr. Manuj was mentioning about the red flags. Like Ashok mentions, I also is predominantly veering towards the CR with the UC backup. That's the way the PS is sort of going out of the horizon in most cases. 4 degrees is my sort of a gospel, sort of a slope I give, not more, basically because I'm more concerned about infringing into the PCL island at the backside. Soft bones, Manoj, sometimes if you're trying to stuff the tibia, they tend to sometimes just pull out. Second scary point where I question the compromise of the PCL quality is absolutely the osteophyte behind. You palpate the PCL and you know there's something hard sticking behind, which is continuity of either the posterolateral or the posteromedial side of the tibia. By the time you take out all this, you find that the thickness of the field of the PCL is not so great. No point taking a risk for the next decade. Rather do an ultracongruent, which is working as well for that matter in that cases. So I think, anytime PCL needs to be recessed for balancing the ML or for whatever reason, it is ultracongruent.
Yeah.
I think balancing has we have an intact PCL or no PCL. I mean, that's what we follow in this case.
I agree, Suri. To your point, we actually compared, we published this in the JOA, I think 2 years, 3 years ago, comparing UC and CR. And patients actually, and we did a gait analysis study, the UC component, the cohort of patients, the UC actually had much better results in terms of, stride length, the pressures in the forefoot, midfoot, the time on the swing phase, and all of those. So yes, UC is definitely here to stay. And I think more than UC, I would stick my neck out and say possibly MC is here to stay. So these two congruent designs are really the ones that we, 5 years from now, CRs and PSs will probably be available, but on the back burner, and these would be your front runners.
Fantastic, sir. On that note, thank you very much.
Thank you, Parag. Thanks.
We go to the next talk, but I want to welcome our president. He has joined us. Welcome, Shinde, sir. And I want to tell one thing about Raj Gopal, sir. Many people don't know. His first love, I think, is still TKR, but I think in the last 18 months, his first love has become the mouth organ, and he plays it so well. So Ashok, we just want to show you one of the recordings done yesterday by our own Raj Gopal, sir, and then we go to the next talk. So just 2 minutes, Ashok. Fantastic, sir. That was outstanding.
Thank you. Thank you very much.
So nice, sir. I think we all have to have some instrument or some go-to hobby, and I think you have found it in the mouth organ. So with that, I request Shinde sir to please say a few words. He's our president, and the MOA Masterclass is his brainchild. Sir, would you like to say a few words? Then we go to Dr. Harish Bendi's talk.
Can you please continue the meeting?
Okay.
Only thing I want to convey you all. I was in IOAEC. It is just finished. The resolution regarding the IOCON 2021 is passed. It will be held in Goa from 21st December to 25th December in Shama Prasad Convention Center. Nearby most of the hotels we have booked. Within 2 days, you will receive the brochures of the same. Thank you.
Thank you. Thank you so much for that announcement. And we now go to the third talk by none other than Harish Bhende. Harish Bhende needs no introduction. He is a very famous and a popular arthroplasty surgeon in the Indian continent. He's also been the president of IAA, vice president of Bombay Orthopaedic Society, the founder member of ISHK, and he has done a 1-year Ranawat fellowship. All of us have been there for just 3 months, but he has been there for 1 whole year with Ranawat sir, and he takes great interest in knee replacement surgery. And any topic you give him, he's always ready. You know, and that's what I really like about Harish. And as you've seen, the discussion from Dr. Suri's talk to Raj Gopal sir's talk, it now flows very well for his topic, which is going to be on how do I increase, how do I use constraint in the primary totally replacement. And a lot of points were made regarding the medial congruent knee, the ultra congruent insert, you know, the medially constrained knees, medial pivot knee. And I think none other than Harish Bhende himself will be a better speaker for this. So Harish, I wish to invite you and thank you for giving us your time on a Sunday evening. So over to Harish to his talk on how to increase use constraint in primary TKR. It's all yours, Harish.
Thank you, Parag. One thing I must say that you really know how to praise others. I was really, amazed at the way you can praise somebody else. And it really feels good to, listen to your praise. Whether they are true or false, I don't know. But I was very happy to hear my, anyway, let me also thanks MOA for inviting me for this symposium. Let me share the screen. Is it visible now, Parag?
Yes, very well. We can hear you well.
Yeah.
It's visible well. Thank you.
Wonderful. Constraint in TKR and the related issues, basically about implant selections. These are the multiple topics which are put together. It is not just about what constraints are there, but also about when we have a constrained implant, what else need to be done during the surgery, with example of couple of cases. So we have got multiple options available to us today because of multiple companies are allowed to sell in India and the market is quite open. So you get completely floored by the amount of options which a surgeon can get today compared to what when we started about 25 years ago. So the question is, which system should I use and why should I use that? And if I had to use certain system, what care I need to take? So basically, we need to get a stable knee and after primary or revision condition. And this stability depends on 2 things. One is the soft tissue envelope, which we can create around the knee joint. And what is the bony structure and how well we can reconstruct that with our implant after removal of the primary surfaces of the bone. So in a salvage situation, both these soft tissues and a bony structure could be affected and we may be having a difficult task at our hand. So selection of implant basically depends on the deficiency of soft tissue envelope and the deficiency of bones. Now, if you look at the implant, there are progressively increasing level of constraint in the implant. What is meant by constraint? The normal knee is moving around on a flat surface of a tibia and a round of the femur. And these actually unstable bony surfaces, the flat tibia and a round femur, they don't have any inherent stability. They are made stable basically by the ligaments which surround them, like ACL and PCL, and the collateral structures, the hamstrings and the quadriceps in the front. So these are all dynamic or a static stabilizing structures. And if you want to preserve this dynamic structure or a static stabilizing structures, and we just resurface the joint, then that will be the best knee replacement one can get. But unfortunately, we cannot do that because in many times with a severe arthritic process or because of damage to the bone and structures, these primary structures are not very well preserved during the process of arthritis. If they are not severely damaged, we can preserve the PCL and do the replacement surgery. So we have got knees which are CR knees, and Dr. Raj Gopal is quite famous for doing all his operation by CR knee in, I would say, 99% cases. Then we have got second level of constraint, very called a stabilized knee, where the PCL is sacrificed and we try to get the stability with the help of some mechanical structure within the implant. And this could be posterior stabilized or anterior stabilized or a constraint stabilized knee. Now we'll come to all these things. What is meant by posterior stabilized? What is meant by anterior stabilized? What is a constraint stabilized? And then the last stage is we call as a hinge knee, where the knee actually has got a hinge between the femoral and tibial component. So there is no question of any soft tissue trying to give any stability. These can be done actually in a cases where we technically resect the distal portion of a femur or upper tibia, or for some reason the collateral structures are completely gone. And in this case, we have to use something called as a rotating hinge knee, where the entire thing depends on the hinge for the stability. So the standard posterior stabilized knee has got a box and a cam design. And basically, this box and a cam design, which has allowed the femur to get stabilized anteroposteriorly. It doesn't have medial lateral stability. So for these knees, we need to have intact medial and lateral collateral structures. If the medial structures are gone, as we have seen in the previous lectures, then this knee can still become unstable and open up medially on a abnormal forces, like you can see in a picture. And second thing is, if the gaps between the femur and tibia are not very right, again, these knees, which are called posterior stabilized knee or cruciate sacrificing knee, are not going to be very stable, because in certain amount of laxity, when the femoral implant can actually go over the tibial post, and you can see that this distance is called as a femoral jump height. So whenever you get a flexion gap, which is quite large compared to the extension gap, these knees are not very suitable. We have to do something more and more constrained design to make the knee stable. Either we have to balance the gap by various techniques, or we have to get the implant which can take us over this inequality in a gaps. So if you have got a big flexion gap, then these posterior stabilized knee like this are not very important or cannot be done. And we use something called as a constrained posterior stabilized knee. And this constrained posterior stabilized knee has basically increased height of a box and a cam, and because of which the knee is quite stable against mediolateral forces as well as anteroposterior forces. And these are the example like TC3 knee from a Johnson group, or a CCK or LCCK knee from a Zimmer group. And various companies have come with their own version of these constrained posterior stabilized design, where they have got a deeper box and a taller cam, tibial cam, which give the stability like this. So you can see on the left side, this is a knee which has got a standard posterior stabilized knee, not a constrained one. So under a mediolateral unequal force, it can open up medially. On the other hand, on the right side, you can see it is a constrained posterior stabilized knee, which has got a bigger tibial cam. So it doesn't come out of the medial femoral block. And hence, in unequal forces, the knee doesn't become unstable. So these are the knee which we may have to use in a case when we lose the medial collateral structures during the process of surgical release. So many times, if you have got a very badly deformed knee and you want to do a knee replacement surgery, then it is a good idea to keep a constrained design like LCCK or TC3 in your armamentarium, so that during the surgery, if the primary posterior stabilized knee is not going to work, we can always replace that with a constrained design and come out of the difficult situation. Now, what about the medially stabilized knee or anterior stabilized knee. Now, these are the knees which are basically with a different concept. They are more of a more than a stability. It is a concept how the knee works. A normal knee, a natural knee, has got a rotation when the knee flexes and extends. And the rotation happens because on the medial side, the femoral component doesn't go anteroposterior as much as the lateral side. The knee, the normal knee, is also a little loose laterally by about 2 or 3 millimeter, because of which when the knee flexes and extends, the lateral compartment or lateral femoral condyle comes forward more than the medial compartment. So there is some sort of a rotation which happens, but the rotation doesn't happen with the center of the tibial plateau as a axis of rotation. It happens by vertical axis, which is around the center of the medial tibial component. And this has been recreated in a knee design in certain knee components, where the medial component is something called as a ball and a socket design, where it is quite congruent to each other. There is no significant anteroposterior laxity kept, and hence it flexes and extends in the same position. There is no anteroposterior laxity. And the lateral component is made more flatter on the tibial slide. So because of which when the knee flexes, there is a more translation of the lateral femoral condyle front to back. And you can see that in a picture. These are the components which are going to rotate not almost like a normal knee. But again, these rotation basically depends on the collateral balance and the posterolateral balance of other soft tissue. Just because we have a certain design in it doesn't necessarily mean that the knee implant in the terminal outcome will behave like that. So these are the medial stabilized knee. And when we talk about the anterior stabilized knee or a dip dish knee, what the companies have done or what the designers have done is they are given a tibial surface which is much deeper than a normal. So there is a more depth of a concavity of a tibial surface. So automatically the anterior edge of a tibial plastic is little taller than the anterior edge of a standard PS knee. Because of which when the knee tries to go forward, the femur tries to slide forward, the raised anterior edge will prevent the anterior translation. And that is how they get a name called anterior stabilized knee or a dip dish designing knee. Basically, these are the inherent stability mechanism incorporated into the mechanism of the design of a knee. It has nothing to do with the actual soft tissues around the knee joint, which could be slightly unstable, and then that is taken care of by, to some extent, not fully, by the design and a knee joint. So this is a medial stabilized knee from a Zimmer company. Again, they have mentioned that the medial structure rotate less, the lateral structure rotate more, and hence there is a normal rotatory effect with a pivoting on the medial condyle of the tibia. And because this is not a box and a cam design, the stability is given by the plastic which is which is made in such a design that there is a more anterior ledge. The bone is preserved, so you prevent the resection of the medial box. These knees obviously are more bone preserving, and if you want to revise these knees to the second implant, then because we have a box, we can then go to the posterior stabilized knee or a TC3 knee in this situation. So basically we can preserve the bone in these knees. Then we come to the hinge knee, which is the higher level where collateral structures and mediolateral structures are completely gone. And the hinge was in the past used to be fixed hinge, but people realize that the fixed hinge doesn't work because it puts a lot of stress on the bone and implant bone junction and it fails. So there was a very high rate of failure. So today we don't talk about fixed hinge. We are always talking about rotating hinge knee. And what happens is it has got a hinge mechanism like this. And you can see that the hinge mechanism allows the knee to flex and extend in a uniform format. The skill of a surgeon in utilizing these knees is to get that hinge mechanism to the level where the normal hinge of the patient's knee was. Because if you do not match the normal hinge of the patient's mobility to the implant mobility, then the knee may not work very well. And these also have got a rotating mechanism on the tibia where the plastic can rotate into the tibial component. So these rotation and hinge both allow reduced amount of forces going on the implant bone junction. So this makes them more stable, and the life of these knees are much longer. And we have got long-term results of almost about 10 to 15 years with a rotating hinge knee. while in the past, the fixed hinge would fail in 2 to 3 years' time. Now, these are the knees which are the next one, where we can have a resection knee, where we resect the entire component of the femur, like in a case of tumor prosthesis, or when there is a significant destruction of a distal femur because of trauma, and in which case the entire femur is lost, and then it is replaced by a metal femur augment along with the tibia. And you can get these kind of a modular resection prosthesis, where we can reconstruct the knee, keeping the only surrounding soft tissues, and the entire bone and a joint structure is entirely replaced by the mechanical structure. So these are got a tumor resection knee or a global modular resection prosthesis. Now, just an example, this was a case where we have got a trauma, badly damaged lateral condylar structure, and a surgeon has done reasonably good job of reconstructing that using double plate and anteroposterior screws. And they have gone by probably by resecting, removing the patellar insertion to get better exposure. The post-op X-ray looked very good. Patient was very happy, but eventually over next 3 to 4 years time, this femoral condyle, which was fractured, started developing avian. It collapsed, and eventually patient had a significant amount of instability laterally. And this patient required, because of unstable knee and pain, revision to knee replacement surgery. And hence the revision was done using a constraint design, because we had to use the augment on a distal femur, and we have to use the constraint design because lateral structure was significantly unstable. And whenever we use a constraint design, we have to realize that when a surgeon uses a constraint, more and more constraint, it puts a lot of stress on the junction of an implant bone. And many times with a longer constraint or a bigger constraint implant, we may have to increase the stability of the implant fixation to the bone. So we may end up using stems and augments. Now, these stems and augments are essential part of the surgery. So we cannot just talk about constraint unless we talk about also the associated use of stems along with this implant. So this was a picture. Now, when we talk about stems and wedges, basically we talk about stem, what length stem you have to use. It is not necessary always to use the longest possible length. We can use a small length and we can cement the entire stem in. We can use a long length, which can be fixed by a non-cement technique into the medullary cavity of the femur or tibia. The stem could be straight, curved, bifid. It could be smooth. It could be fluted. It could be canal filling, or it may not be canal filling. So there are various types and options of stem. But the principle is we must use some stem when you're talking about using a high constraint design like TC3 or LCCK, so that we don't end up having a implant becoming loose from the bone because of excessive stress put on the junction of bone implant. These stems need to be on the bone end, and the location of stem in an anteroposterior has to be properly balanced so that there is no excessive anterior offset or excessive posterior offset. So these things has to be managed by the surgeon when they are using a stemmed implant. Now, when you talk about stem, we also talk about wedges, because sometimes the knees have significant defect and we want to fill the defect before putting a constrained knee. And for that, when you have a defect like this, we are clearing the defect, putting the wedge of different types. It could be full wedge or it could be half wedge. And then we get a flat surface on which your implant can put. Now, when you put a wedge, the forces which comes on a wedge are diverted to the directional inferior forces and the forces which push the wedge away. And to counter that, bigger the wedge, bigger these displacing forces, we have to use a stem along with that. So basically, these wedges and stems need to be used in an implant where constraints are high and there could be higher forces on the implant. So the stems will prevent these loosening. Another example, this case had a bad HTO done before coming to us 3 years earlier. Patient hasn't walked since then because patient was very painful, stable. We are talking about the right-sided knee where there is no implant. The opposite knee also had a pain, but it wasn't as bad as the right knee, and patient wanted something for the right knee to be done. So initially, the simple plan would be just resect the proximal tibia and use a bigger implant like a tumor prosthesis, and then everything will be much simpler. But the patient wasn't very affording. We wanted to do something better, and we planned to do a primary implant for this patient. So what we did was we took a small vertical resection of the upper tibia very close to the joint surface. To do that, we had to get access. So we did a tibial tubercle osteotomy, a long one like this. The tibial tubercle and the patella was separated and removed away, so you can get good access to the tibia in the front. And then we had a resection, proximal resection at that level, about an inch from the upper surface, and we remove this upper tibia like this. So automatically we could get this triangular piece out. The tibia distal part could be aligned with the proximal tibia, and we couldn't get a proper implant proximally with a long stem. And the final picture looked like this. This patient had got eventually good outcome. She was able to walk very well. It's almost about 8 to 9 years in the surgery, and she has got a good gait. You can see that the knee, which was significantly deformed, could be balanced back to normal using a constraint design, and almost like a primary knee instead of a very high level of constraint like a tumor prosthesis. In case of revision, like when there is a lot of bone loss, you can have a spacer which is removed. This is the stage 2 part of a surgery. And we can see that when you reconstruct, we need to have a constraint design. So this was designed with a TC3 type of an implant where there's a higher box and a cam. This is the post-op picture. You can see that the box is deep and a tibial post is quite tall, and this allows good primary stability. In this particular patient, although it was a revision case, there's good amount of soft tissue balance which was there. The soft tissues were not damaged, and the balancing can be done very well. So we didn't have to go for any further constraint in the design. That's a post-op picture. You can see that we have used a stem on the tibia and femur, because as I mentioned, if you use a constraint design, we must have additional stability of implant to the bone. So basically, if you have to make certain decisions, first of all, you have to talk about or you have to take a call on, can I get a good soft tissue balance in this particular knee? If you feel that you are balanced at the end of the surgery after taking the bone resection is very good, you have got a good medial and lateral stability in a flexion and extension, you can simply go for a primary implant. It could be either a cruciate sparing or a cruciate sacrificing. But if you feel that my soft tissue balancing is not going to be very good, then you have to think about what constraint I need to use. Could be just a PS knee is okay. Should I go for TC3 knee? Should I go for something more than that, like a hinge knee? We also have to think about how much bone loss is there. Do I need to use some kind of a bone augment, like a bone graft from the primary bone which is removed? Do I need a wedges or augment or a stem? And we have to make sure that these options are kept available during the surgical planning. We also think about offset stems and other options, and then the sizing of an implant, because many size we may have to upsize or downsize an implant to mix and match the soft tissue balancing. Like if you've got a large flexion gap, we may need to use a bigger implant. So bigger femur has to go on a smaller tibia. So you must have a system which will allow you this upsized implant compatible to the lower size tibia, and that mix and match should be there. Most of the today's systems allow you to go at least 2 sizes up or 2 sizes down to match the upsizing and downsizing of the femur when you try to balance these difficult knees. So sizing of an implant also need to be thought about. So selection of implant basically then depends on the deficiency of soft tissue envelope which you can get at the end of balancing the thing, and the deficiency of bone which is there. So level of constraint basically depends on the surgeon's assessment of the stability and instability during the surgery. So it is very difficult to give you a single thing, but it is very important that constraint is a ongoing process. It's not a simple thing that I always use X type or a Y type. Depending on the difficulty of a case, you must keep multiple options ready, including sometime even a hinge knee ready for some of the primary cases. Thank you very much.
Thank you, Harish. That was an excellent talk, and I compliment you for really clearly explaining the concept. The floor is now open for questions. I want to ask you about, even Suri alluded to the medially constrained knee, the medially congruent knee, and you did mention about the medial pivot knee. So, and Dr. Ashok Rajgopal also said that in the years to come, PS and CR would be outdated and probably we would be moving to this ultra congruent knees. So what is this medially constrained knee or the medially congruent knee? Can you explain a little more to us?
Basically, the normal knee, the natural knee has got a medial tibia, which medial femur, medial condyle of the femur, which doesn't go anteroposterior much. There is no translation as much as the lateral side. And because of which when the knee flexes or extend, there is a rotation of the femoral component on the tibia. And this rotation is not what we get in a rotating platform design. Like when we use the rotating platform design, the rotation happens again the center of the tibia. So when the lateral component or lateral femur goes behind, the medial component comes forward, which is against the natural knee. In a natural knee, when you flex the knee, the lateral component go more behind and a medial component go less behind. So because of which there is a relative rotation. Now this relative rotation will not happen in a standard rotating platform design. What happens is exactly opposite. To counter this, some of the designs or designers came with the idea that we should have knee where we can get a ball and a socket joint on the medial. So medial side tibia is more congruent compared to the femoral condyle. So there is no anteroposterior translation. There is only flexion and extension around a single point. On the lateral side, it is less congruent. So the tibial component is flatter and longer. So these knee theoretically mimic the function or the rotation of the natural knee. It is presumed that this will work better and patient will feel better. But I was doing a literature research in the last 2 days and found out that there is no conclusive proof that these knees always do better. There are enough articles which show that when they try to find the patient's happiness or a patient's walking ability by a fluoroscopic technique, they haven't found any significant difference between the two type of knee, because it is not just a design, but as Surya has mentioned, it is also the alignment which matters. It also the soft tissue balancing that matters. And if these things are not done very well, you may not get the identical outcome. So it's very difficult to judge which knee is better, although on paper, the medial pivot knee appears to be superior in terms of function.
Okay, so any comments from you, Manoj, and then we can ask Dr. Sarang for questions. So Manoj, your thought process on the constraint of knee, and you're going to speak about the revision, of course, in the short course of time. But you want to ask any questions or any comments on Harish's talk?
I think Harish has nicely summarized the flow of constraint right from the CR to the PS to say LCCK, CCK versions to a hinge. That seamless flow is very, very important. And on the table, you need to use a platform that gives you seamless flow from the basic to the advanced. So I think that's a very important message for all people, because many times we get surprises on the table and we need to be ready with the backups.
Right. Sarang, you have any comments?
So on very few occasions, we get to be surprised on table. If at all we have done our homework priorly, but nobody is immune, we do get surprises. So in situations where probably the surgeon has to scale up, this is particularly in relation to talk of Bhende sir, his experiences in augmenting the MCL instead of stepping up with the implants.
If the MCL is actually avulsed completely from or split into soft tissue, because many times we are used to do so-called pie crusting. I also do pie crusting in a tight structures, but many times you find that if in a very tight structure you do a little extra pie crusting and try to put a little bigger insert, it may snap. So it is the MCL is snapped intra-substance because of pie crusting or because of release. And that's a bad news, because that is very difficult to repair. More often, especially in rheumatoid knee, I've seen MCL can get avulsed from the femoral side. You can see a crack and it avulses up. If it is avulsed from the bony attachment, then it is not so difficult, because you can just put either a small plate or just a couple of screws with the washer and protect the knee for the next 4 to 6 weeks. Do not be very aggressive on mobilization. And these knees in the long run do very well, except they may not get as much range as you think about. I have the incidents few times when I got an MCL which was ruptured on table, and I hadn't kept a option of TC3 as always, because as you rightly said, unfortunately, we may not be in a position to get everything on shelf like abroad, Even in Bombay, sometimes we do not have those options immediately available. In which situation, we can use some kind of a, the Ethibond or some kind of an anchor suture. Fortunately, we have one of the good arthroscopists in Mumbai who practices along with us. And these anchor sutures can be used to reef whatever soft tissues which is damaged and then protect that. Sometimes you can use the long hamstring, and you can use that as an additional tether to get the soft tissue or biological structure, and then you have to keep that knee protected for a very long time, 3 months, 6 months in a hinged knee, and don't go very aggressive on mobilization. We actually want this knee to be a little stiff. All these things may work, I would say, in about 50-60% cases if you and patient are lucky. But reefing the snapped medial collateral, which is snapped because of your excessive pie crusting or because of excessive release, is definitely a bad news. If you don't have a constraint design, that's worse news. So you may be prepared that this patient either will become unstable and either come back to you if you counsel him well, or go to somebody else for revision. So that's a difficult case to handle.
Great. Thanks, Harish. That was a.
Can I just add one point in this, Parag?
Yes, Suri, please. Suri.
Basically, alluding to that question, if you have insubstance tear intraoperative, I think it is a little better than a late rupture. That's one. Number two is in what Harish was saying, I think he has covered almost all possibilities what you can do. But what we have seen is in tumors, when we had the abductors had to be repositioned, when you had no greater trochanter, basically you can augment a little bit also with the Marlex mesh. It somehow induces, I've revisited some of these cases into that area, they induce some intense fibrosis. So take a small strip of the hernia mesh and then just weave it along suture and do all the protectives Harish advised. Exactly. I mean, if you can up the constraint, if you have it, fine. Keep the knee in about 40 degrees of flexion for about a week or two, gradually passively mobilize, but protect it with a hinged brace for at least about 6 to 8 months.
Great. Any other comments or questions? Yes, Parag.
Perhaps, sir, in a similar case, going ahead with the same thing, augmentation with a fiber tape with suture anchor 5.5 double, I guess they will also be allowed in situations where we don't have ATRAC other components to step up.
Okay. Yeah. Any comments, Harish?
I mean, if you don't have suture anchors, if you don't have these tapes, then what I normally use is use the Ethibond size 5 number, or if that is not there, Ethibond 2, which is available more often because many times people use it for a THR cases to repair the posterior capsule. And then we make a small holes along the upper tibia and upper femur, which go from mediolateral, and use the run-out technique to pull the stitches from there. You need a long straight needle with it's ordinary needle, long straight needle. So you can use Ethibond 2 number to repair and reef those structures. But as Surya has mentioned, if that small thin MCL which you are released snaps after the closure, may 2-3 few weeks down the line, that's a bad news. If it happens on table, you at least can repair it, reef it, and hope that things will be controlled to some extent.
Right. Thank you. So one quick question to all our 3 speakers. So what are the implants which you use in your standard practice, Harish, when you're doing a primary knee in terms of CRPS?
I always use, I always use posterior stabilized knee, rotating platform design for the last 8-10 years.
So 100%.
And I find that is extremely good because I don't think the medial pivot, etc., is important, because what we fail to understand, the pivoting movement of the knee is not because of the bony geometry. In fact, the medial femoral condyle is convex, not a concave. Medial tibial condyle is a convex, not concave. And what we get is a plastic is concave. So we are not going by the so-called true geometry of the tibia and femur. And that rotating movement happens because of the screw-in mechanism of 4 ligaments, 2 lateral medial and 2 anteroposterior ACL, PCL. Will you have a same screw-in mechanism in an ACL or a PCL deficient knee? Well, correct. You don't. Correct. And all the knees, we are removing ACL definitely, and sometimes even PCL. So how do you expect that you get that movement?
So you use PS and 100% rotating platform all the time?
That's correct.
Wow. Okay. Manuj, what's your implant distribution?
I'm almost always a CR.
Always CR. And how many times do you have to go to an ultra congruent insert?
Very rarely. I mean, if I have to move to, if I'm supposing very loose or my PCL is gone, at those stages, I would like to move on to a PS rather than ultra congruent.
So you'll move to a PS. So your choice is to move to a PS rather than
If at all, I mean,
ultra-congruent
which is
constraints.
very rare, I find that things are not good. The PCL, as Suri also said, you have excessive amount of slope. The remnant of the base of PCL is very weak, and I believe subsequently it will lead to a late rupture of PCL. In all those cases where I have a sort of thick feeling, I would like to do an overcorrection and do a PS knee in those cases.
And any experience with the medial pivot knee or the medial constraint?
Like Harish said, when it came in a big vogue, I tried for 300-400 cases, but I did not get comfortable with that.
Okay. So no longer you are using it.
Yeah, I also used a huge number of this kinematic aligned knees, the Journey BCS and the Journey CR in a huge numbers. Again, what the company proposes versus what comes on the floor was not the similar. I could not find any significant difference in functional outcomes using those kinematic aligned knees.
Okay. Yeah, Suri, what's the distribution of your implants in a primary knee?
70-80% CR.
CR. Okay.
You ultra congruent backup.
Okay.
Except in some sort of hyperextension, in some situations, probably I may go for a PS that may be about 5%, less than 5.
PS. So I think
medial pivot or other things for the I need a significant reason to change.
Right.
With
So
the current outcomes what we have.
2 of 3 of our speakers are now using more CR knees. For me, I do 100% PS, and the modular knee. I have not used much the rotating platform yet. And the ultra congruent also I haven't used, but I think the time has come to try these choices. But right now it's 100% PS. Okay, so thanks Harish, it was an excellent talk. And we now move to the last talk. And after that, we are going to have Rajiv Bajaj give a talk on a very nice non-academic topic. So please be there, hold on. It's now my proud privilege to introduce to you Manuj Wadhwa, who's a close friend, and I've known him for a long time now. He's currently the chairman and the executive director at the Ivy Light Institutes of Orthopaedics and Joint Replacement, also the director at Fortis Hospital, Max Hospital, Paras Hospital. He has done his MCH in Dundee and he's done his Ranawat Fellowship also, and both of us have been there at these 2 places. I also want to let you know that he has a big passion for knee replacements, and he has got several awards and recognitions, and he has got many records to his credit in the Limca Book of Records for the highest number of knee replacements in a year, in a week, and a month also. He also has been recognized as the Man of the Year by the American Biographical Institute. And has also written many papers. And more than anything, I think he has a big love for joint replacement surgery. And the best introduction is that he's my brother. So thank you, Manoj, and thank you for accepting this invitation. We look forward to hearing your talk in continuation on the implant options in revision knee replacement. The ball is in your court now, Manoj. All the best.
So thank you, Parag. Thank you, Dr. Shinde and Maharashtra Orthopaedic Association for giving me this platform to speak today. Now, as we move on to a high acceptance of primary knee arthroplasty, so exponentially there's an increase on revision also. So the principles of a revision do not change. Basically, you have a defect, you need to fill that defect with the one or the other kind of an implant option with bone or metal. You also have to restore the flexion extension gap and maintain the posterior offset and restore the joint line. But a simple message for continuing for all my youngsters who are listening out here. If you're not doing a very high volume of implants, remember the gold standard, master one particular implant system, because every system is very intricate. What you need to choose is, number one, what is available to you in the industry. Number two, it has a flexibility, as Harish said, for moving at a platform from a CR to a PS to a constrained condylar to a hinge. So you should have all those platforms so that you can plan from your simple revision to an ultra complex cases. Yes, in those cases where you require sleeves and the parameters is a different case scenario. So in the beginning, you should be very, very careful. You have to master one particular implant system. So these are my disclosures. Here in revision, what we have is management of bone defects. So you have a type 1 defect, which is normally the simplest of all. Type 2 defects, where the cortical rim is intact but central metaphysis is lost, you can manage with majority of your revision implant systems. The point is, where you have the loss of entire metaphysis and cortex is the severe case scenario where you need to have zone 1, zone 2, and zone 3 fixations going all across. So augmenting fixation and revision, as Harish told you, you need to have metal augments. It's basically wedges in the tibia and metal augments in the femur. So in the proximal tibia, you have different kinds of wedges to fill the kind of defect you have. In the femur, you have the distal as well as the posterior wedges. Also, these can be solid or these can be tubercular metal. It can be COCR, it can be titanium, different metals across. And in complex cases, you need to have the backups of modular metaphyseal sleeves and cones. In tibia, majority of the defects can be managed with a step wedge or a hemi wedge or a partial wedge case scenario, depending on the implant system you have, whether you have a TC3 system or you have a Legion revision or you have a Zimmer next gen revision system, LCCK revision system. You will have different kind of platforms available with you at different angles, different thicknesses, 5, 10, 15 that you want to use. So before talking on these wedges and the preparation of wedges, remember one simple rule. Never prepare your tibia for a wedge till the time your rotation of the tibia and the femur is set. You have to first set the rotation of your tibia, then come back in and transact the space for your wedges. So depending on the platform you have a step wedge, you have a full wedge, you have a hemi wedge, you have a send 7 degrees, 22 degrees, 130. So all different platforms will give you different modalities. In the femur, you have distal augments, you have posterior augments, you have an L augment, which is the distal and the posterior combined. Again, different thicknesses, 5, 10, 15. Majority of these are titanium these days. Now, the tactic when you're using all these augments is A, you have to use a corresponding or smaller augmentation than the defect. Whenever you are buttressing on, you have to restore the joint line. The distal augmentation is extremely important, rather I would say more important than the posterior. And if any of your augment is more than 4 millimeter, you require to use the stem. So stems are increasingly used in total knee replacement in a lot of primary as well as revision cases. And also you need to have these things available. If you do not have a bone bank or bone graft facility, then you have to have these sleeves and cones for managing your complex revisions. Why stems in revision? Because if you use a surgery without a stem where you do not have a proper cortical support, you will have a subsidence. Gradually, the loading will happen up and you will have a sinking of your implants and aseptic loosening and subsidence. So when you use a stem, you have a hold not only into the zone 1, but also into the zone 3, which is the diaphyseal zone and the metaphyseal zone. They protect your fixation interface, offloads stress from the bone. What kinds of stems you have is always huge controversies. Harish also said you have a long stems versus short stems. You have straight stems and offset stems. I'll explain you a bit on a small video on the usage of offset stems. So these are the different kinds of stem systems. You might have a sort of a single bullet shaped stem, or you have a fluted stem or a slotted one. You can have, depending on the canal and the anatomical geometry, the usage of straight versus the offset stem. The use of stems basically is A, you want to prevent your metal augment and protect it. You have a weak bone or osteoporotic bone, you need to support that time. You have a bone graft, you need to augment that. And you want your load to be going on to a wider substrate area, and you want to fill up the defects. Now, the baseline we all have been using even today is cemented stem. So if we have a bad diaphyseal bone with a huge canal diameter, type C canals, unfavorable canal shape, so I always call it as a stem for all geometries. So you can use a cemented stem in any kind of a metaphyseal, diaphyseal mismatch. And the advantage is it gives you more options for implant position, immediate delivery. If you want to use antibiotic delivery, then obviously cement gives you that advantage. In a cemented stem, there are less chances of stem tip pain, which is an issue with uncemented ones. But the only caveat is they are difficult to remove. These days, the trends are more moving on towards the uncemented stems, and you have a modified features with us. Now, rather than the heavy COCR stems, it's mainly the newer systems use titanium. The whole idea is you don't want a tip pain, so you have to reduce the rigidity. So you have these kind of cornel slots, so that a stiffness and rigidity is reduced. You have the trifines or the flutes for a better rotational control. So you don't want a tip pain. The prerequisite is you need to have a good diaphyseal bone to match up these stems. So if you are using an uncemented stem, the true advantage is there is less bone loss during re-revision. Disadvantage with the old designs was stem tip pain, which with the newer offset designs, understanding the true kind of an anatomy, and the new kind of design of stems, these things are much reduced. So now for using an uncemented stem, still there are issues that one needs to understand. In a lot of our bones, especially if we talk about the tibia, we have a coronal bowing. So if you use a straight stem going down to the diaphysis, you will have an enteromedial overhang because your diaphysis does not match very well with the proximal articular surface. Also, the intramedullary canal is not patent. Similarly, for the femur, if you have a bowing of the femur, you have a tendency to hit on to the interior cortex. All these things are managed with offset stems. As you see the picture on the left, if you use a straight stem, you have an overhang going enteromedially. So an offset stem design allows you optimal implant position. So if you see this kind of a picture into a femur and a tibia, and you see the central canals are very, very patent. In those situations, you go in with a straight stem, straight uncemented stem, which gives you a good hold into the diaphysis as well as the proximal articular surface, and you're very well to go. Now in the next situation, where you get these kind of situations where you have a bowing of the femur. Now, if you use a long stem in these cases, you will be hitting onto the cortex. Along with that, your femur is going to be flexed. You will have a large flexion gaps. So the way to get across is use an offset stem. It will centralize into the canal and also give you a distal articular surface control. So in all these situations, where you have a tibia and a femur and a patent canal, you can always manage the asymmetry of the canal with the proximal articular surface using these kind of offset stem positions. Now, in these situations where you want to use the offset couplers, you have a 360 rotation possible in the new kind of design, so that what is the best possible position in the AP as well as the ML position can be analyzed. Now, depending on the implant designs, you have different kind of offset systems available. 2, 4, 6, depending on what system you are using on. It is a modular or a non-modular design. It only gives you a translation into the AP plane, or it gives you 360-degree possibility of translation. Again, depends on the design. Now, these offset stems are a real good indication if you are doing a high volume of revisions, because they will help you bail out any kind of ML or AP overhangs. Also, you do not want to be central in the canal and use a very small size of the tibia. So any kind of a mismatch into the metaphyseal role, like getting off situations, which is a revision of, say, high tibial osteotomy conversion, or you want to have a distal femoral osteotomy conversion. These are the parameters where your distal canal might not be patently going on to the center of the proximal articular surface. The second thing is malalignments, where your metaphyseal defects are there and soft tissue alterations do exist. So remember, if you have an asymmetry of the canal of the femur or the tibia, the answer is an asymmetric stem. Also, in cases like Dr. Raj Gopal mentioned, restoring the posterior condylar offset was a very important part. Similarly, majority of the revision cases, we will always have a huge flexion gap as compared to the extension gap. So the way to buttress those situations is use a large size femoral component and translate your femur down, build up your sort of posterior condylar offset, build up your flexion space. You will be restoring your joint line and posterior condylar offset. So it bails you out of all situations. For all fixing these stems, you have these kind of offset couplers which come in different sizes. Now, for a very small sizes canals, we have the male to male couplers. Now, Since the time we have been using these kind of revision platforms, there are definitely issues considering the revision case scenario in Indian systems. A, we have very small size bones. When we have very small size bones and we use these offset couplers, you grate off entire anterior cortex, which needs to be taken care of. You have osteoporotic bones, severe bone loss. Now, also in these canals, if you use a straight stem, you will be hitting onto the cortex. So definitely offset stem bails you out, but the couplers become one issue for very small bone sizes. So usage of stem to include, you use a long stem having a wider control than short stems. This is our scenario. Yes, certain people like to use short stubby stems also for morbidly obese patients. And now what Harish told you was a platform where you can translate from a CR to a PS to a CCK to a hinge knee. Yes, the philosophy remains the same. Can you do a revision with the least amount of a constraint? Like this case, a failed uni case, aseptic loosening, subsidence, and spin out of the bodily thin spacer. You move back in, do the simple principles of revision, maintain a host bone. In those cases, since your lateral proximal tibial plateau is intact, that becomes a platform to move on. You can still move back, do those revision, fill up the defects with bone graft, and come out using a stem and a simple CR knee implant, and your revision can be done. So least amount of constraint going on, and a couple of these kind of revisions can be handled and handy with these basic systems. Now, you also on the converse get parameters with a huge zone 2 and zone 3 defects. Now, all those cases in complex revision cases, you have these kind of bone defects in aero type 3 defects. Yes, one of the ways is you have these kind of huge defect, you use a bone graft, but bone graft facilities are not available at majority of places and they have their own downsides. Now, if you want to use metal to fill up these defects, say there are cones, tubercular metal cones, depending on different sizes and shapes in the proximal tibia and the distal femur to fill up these defects to bring the joint line back in shape. So the cones can be used in revision total knee scenario. Another beauty of using these cones is that they are not fixed to the kind of revision system you want to use. So you're not bound up, you're not married to it. You can use a cone, fill up the site with the bone graft, and you can use any kind of platform for revising your knee. They create a solid foundation for the implant. So that was tibia, now this is femur. You can always use a metal cutting tool to cut on to the kind of defect you need to fill up. Once the defect is filled up, your zone 2 is filled up, you come back in, restoring the joint line, using the femoral and the tibial augments and the stems, and manage your simple revision as you would have managed. Also, in a lot of cases, the asterom noils, which Harish and everybody mentioned out, is stepped macro design. You have sleeves, the modular metaphyseal sleeves going in the femur, the distal femur, and the proximal tibia. They come in different sizes. Now, these give you an additional maneuverability of internal, external rotation up to 20 degrees. So in a lot of cases, you do not require offset stems if you're using these kind of implant systems. When you have huge defects to be filled up, the zone 2 needs to be filled up, zone 3 needs to be covered up. So these are the sleeves that you use for the proximal tibia and the distal femur, the macro step design, converting the shear to an impaction forces using the Wolff's law, and you move on for this. Now, as we rightly said, keeping the armamentarium of these implants ready, you have to be ready with hinges in special situations, like you have a known MCL insufficiency, as we discussed in the last case. You have a bone loss violating the collateral ligaments. You have a deficiency of the extensor mechanism and the polio cases and the neuromuscular defects, or a huge flexion extension mismatch. Those are the indications where you have used different kinds of hinges that are available, and these hinges bail you out for such situations. So take home message is, plan your surgeries well, work on your implant system, see what is the kind of bone defect you need to cover up, what is the kind of armamentarium you have to have on the table. And I'll show you a very small video on managing of these defects using, say, offset stems. So this is a case scenario where we're going to use a revision system, 55-year female with aseptic loosening, subsidence, failure 4 years after surgery, collapse happening up, all infection markers are normal. So the principle is the same. You have to have a safe and effective implant removal. Use different kinds of systems. I normally use a fine saw to cut interface between the metal and the bone cement, and use very thin osteotome straight as well as the offset designs. So the whole objective is move to the side, use this kind of special offset punches, take out the femur, and you have retained majority of the host bone. Now, tibia in this case was simple, it was collapsed out. Now comes the main story. How do you fill up the defects? So first thing is prepare a raw bone surface, take out all fibrous tissue and see what is the defect you need to fill up. The intramedullary tibial resection is the forte for all these revision systems, maintaining the normal slope, and see what kind of size you need to put up. Now, when you use a neutral bushing in this case, a straight stem neutral bushing, you're offset and you're proud. Now move on to an offset bushing. Say we are using 4 millimeter as a design. You are way too proud into your containment into the AP as well as the ML dimensions. A 2 mm offset gives you a very good containment. Now, since you have a 360-degree position of possibility of movement of these base plates, you see which is the best position marking where you have the best containment into the AP as well as the ML planes. Once you have identified the market, go back in and use the tibial counterbores. You also need to prepare special place and special sort of a grommet for the maintenance of the offset couplers. So this is offset coupler counterbore. Once all this is done, so you have a tibial base plate, then you have an offset coupler, and then you have a stem. You have to be very particular what is the marking you had initially. So that is maintained. Once that is maintained, you have a stem, which is going to have your endosteal control. When you're putting these stems, very important to have a good endosteal control because you don't want to use any cement over there. Once tibia is fixed, move on to the femur. Intramedullary drill, see what is the kind of reamer that you want to use it and depth you want to get in depending on the platforms you have. Femoral sizing is extremely important. Now, size 2 was too small, size 3 is good enough. The moment you use a neutral stem, you are way too proud. Now again, we are using an offset coupler, which is 2 millimeters. Now see where you have the best translation. If you move it totally down at 9 degrees, we have the best possible containment on the ML as well as the AP planes. So placement is set, sizing is set. Now use the trans-epicondylar axis and see we are flat onto the tibia. Refreshment of your anterior posterior cuts, and now preparation for the femoral counterbore. Once this is done, the offset coupler counterbore comes into the space. You have markings onto the femur and the tibia. Now, in small canals, very important, when you use this offset couplers, the anterior bone normally chips off. Assembly goes the same way. You are a femoral implant trial. You have an offset coupler, which is marked to the same position as we had on our trialing jigs, then the stem. This assembly is locked in place, trialing is done. So in these cases, posterior condylar offset is maintained, your flexion extension gap is maintained, you move back with a simple high flex PS insert. Prepare out the box, no point of using constraints, a simple PS insert would bail you out. You have balanced flexion extension gaps, and these kind of revisions, you have the protocols moving the same way as the primary. Implant assembly goes the same way. You have a base plate, you have an offset coupler, and then you have the stem. You get these kind of set screws which need to be fixed on both sides for both the coupler as well as the stem assembly. Again, the marking needs to be cross-checked. What is the marking you lined? Same process moves for the femur. Before impacting, you have to be sure that you're aligned on to the markings, set screw locked in. You have these slotted stems to decrease the rigidity. Hybrid cementation, cement only at the junction. No way cement goes across in the canal. So if at all you need to re-revise these systems, you just cut off the cement and it's as good as revising any primary system. So you translate your femoral components, you build up your posterior condylar offset, impact it through. Cement is only into the proximal surface. Use a high flex PS implant like a primary, and you're set to go. So joint line, depending on different markers you have, meniscal scar and proximal tibial surface, you are ready with that. And you have a stem which is well aligned. So My question would remain the same across, and the inputs would be the same for all youngsters out there. You have to master one particular system the best way. Once you have a sufficient volume to move on of cases, that's a time for trials onto multiple platforms. So with this was like an overlaid jet view of the different kind of implant options you have available with you. I'll be more than happy to answer any questions that are there.
Thank you, Manuj. Outstanding talk. Very nicely, in a short time, you covered the entire gamut of the implants available. We have now the question answer session. So let me ask you, you spoke about these stems, the short stem, the long stems, fluted stems, and there's a lot of talk going on about the short stubby stems, which you completely cement. So what is how do you decide whether to cement a stem, not to cement a stem, or just to do the metaphysical cementing as you alluded to, or use a short stem or a long stem? So can you give us some guidelines on when to use which stem?
So basically, if you go back with the literature, there is good literature on either side to advocate through. It's mainly what you are more comfortable with. I, as a process, would like to keep my backup options on table, that if my revision fails, how do I move back in? So that pushes me on, for majority of the cases, to not use a cemented stem, but to use an uncemented stem. So that's my personal choice, but I don't say cemented stems are not good, because there is equally good literature to propose that also. My only indication for using short stubby stems is those morbidly obese patients with a high BMI and sort of an osteoporotic bone, where I would use short stubby stems in a primary case scenario. But for all my revision case scenarios, my personal preference is to use uncemented stems, long uncemented stems, with a hybrid cementation going only into the articular surface, no ways going down, so that if at all, unfortunately, I have to take out those implants because of any revision or any case scenario, I have the backups available with me.
Okay, perfect. One more question. You did speak about the sleeves and the cones. There's always a confusion. When do you use sleeves and when do you use cones? So do you have any kind of guidelines or a flow chart that, okay, this case requires a sleeve or this requires a cone? Any guidelines you have, Manuj?
So my question would again go the same way, that ultimately it depends. If you want to be married on to one particular system, then you have no choice than to use a sleeve, because sleeve you have to use an SROM only or a TC3. You don't have a second choice available across. The advantage of the cones is that I can use my particular any implant system that I'm using on, but cones helps me bail out those cases. But in cases wherever I believe that I want to use a sort of a rotating hinge, especially in cases where there's a huge flexion extension gap, or the cases where there is a huge metaphyseal defects, I would prefer sleeves in those cases, because it gives me dual advantage of a rotating hinge platform with a sleeve design to complement over there. Also, it gives me additional advantage of setting on my sort of a rotation, if at all it is required, because you can independently have plus minus 20 degrees of rotation into the proximal tibia or the distal femur. So that gives me an additional caveat that I would not be using an offset stem, and I would be bypassing those systems with metaphyseal sleeves.
Perfect. Harish, any comments on the cones and sleeves? Yeah, please.
Parag, many times people use a word like, can I use a sleeve or a cone? Means you are presuming that they are functioning in a similar way. But if you see in principle, the function of a sleeve is entirely different than a function of a cone, although they are going to be used in a similar situation. They are used in a situation where bone is defective and you can't use a primary implant, you want to augment that bone. So now the sleeve is the one which get attached to the implant, and it is a part of an implant which is fixing into the remaining bone. Like there is an ice cream cone of a bone into which we put a smaller ice cream cone of an implant. And that ice cream cone of an implant is made by putting a sleeve on the bottom of an implant. So sleeve become part of an implant which is getting fixed into the residual bone which is there. On the other hand, cone is the one which helps to build the bone. Whatever defect in the bone is to be built up with a cone, to which you may add additional bone graft inside. So cone will essentially augment the bone defect. And in that augmented bone defect, we have got a bone with a cone with a better tubular structure now, to which you can put whatever implant you want. Like once you have repaired the defective structure of a bone with a cone and added some bone graft, etc., then you have got a better tubular structure into which you can use any other implant. You can't do that with the sleeve. The sleeve has to be put. I cannot use sleeve from a DePuy and put it on the bottom of my Zimmer implant. Right. So there's an essential difference that cone augments the bone, allows you to use whatever implant you can using a stem inside it, while sleeve is attached to the bottom of an implant and it becomes a part of an implant.
So once you use a cone, can you still use a sleeve if you want? You use a cone
then,
for the
no. You cannot, because when you use a cone, imagine there is a cylindrical part of a bone, and if this is a bone, this is a defect. You have put a cone inside that bone to fill that defect. So now you have got an internal metal structure. Now sleeve basically works by getting attached to the metaphyseal part of a bone. So there has to be direct contact between the live bone and a sleeve. You cannot and you should not cement the sleeve inside, because that defeats the purpose. The implant, the sleeve has to be in contact with the metaphyseal cone. So if you use a cone to augment the defective bone, you have got a metal there and maybe some bone graft. Inside, if you put a sleeve, you are defeating the purpose. All you need is just a long stem to cement inside. So sleeve is more biological.
Did I finish, Harish? You were saying about this sleeve
Harish,
is more
is
biological.
an absolute indication where you would use a cone.
Sorry?
Here's the question.
Absolute indication for a TM cone.
When do you use
I would not use a sleeve.
No. The sleeve needs to have at least some metaphyseal bone into which the sleeve can sink and get a direct contact. If the bone is defective, I need to augment by a longer stem inside. You can use sleeve by itself without a stem if you have got adequate metaphyseal bone, that is the entire ice cream cone, which is intact in the periphery.
Parag, I will add up.
So you cannot, but if that cone is defective, significantly defective, then I have to use a cone. Then I can't use the sleeve because there is no ice cream cone to put my sleeve in.
Right.
In a couple of cases where you have a metaphyseal diaphyseal mismatch, you have an option and an advantage in a sleeve in a parameter. You do not use a stem at all. You use the implant with just a metaphyseal sleeve, which has a very good support into the zone 2. So you can bypass and leave the zone 3. So if you are using a sleeve, it's not a mandate that you have to use a stem.
Yeah.
Right. So any further comments or questions? Suri, you have any thoughts on revision implants? I think Suri is probably not there. I think an excellent talk. Do you have any questions, Sarang, before we go on to the last non-academic talk by Rajiv Bajaj? Okay. So Manuj, again, excellent. You really spoke so well, like always. Thank you for joining. And now we go on to the last part of today's MOA webinar. Just hold on, Ashok. So it's a great privilege for me to introduce to you Mr. Rajiv Bajaj. Actually, he was my classmate. We studied together in St. Vincent's. All of you know, is the managing director of Bajaj Auto. And he was the one who introduced the Pulsar range of motorcycles, which brought up the company tremendously. He has been named as one of the 50 most powerful Indians, and has a great knack. He's a great orator, and it will be a proud privilege to listen to him. Yes, Ashok, can we play Rajiv Bajaj's video?
So there was a time in 2005 when my son was quite unwell, and it was March 2005, and so we were struggling with this, and we thought he was getting better. It was a tricky problem to solve, and we thought he was getting better, but actually I realized he was getting worse. And I remember this moment where And we were living here in this house where we grew up. So I lived here till 2009, from 1966, before I finally moved to my own home in town. So my parents, my brother, all of us with our kids lived in the same place. So I remember that at that time, I was so overwhelmed by the situation that as a parent I am not able to ensure that my child is okay, that I couldn't think, and it had been several weeks of stress and I just could not think at that moment. So I still remember, I just picked up a hand towel, walked down from my room across the house to where my parents' room was, and my mother by that time had already become quite sedentary. So she used to sit on her bed and used to keep looking out and stuff like that. So my father was sitting in his chair, she was sitting on the bed, and all I wanted to do was just go and lie in her lap. That's it. And that's what I did. And I, at least for 5-10 minutes, I cried and cried and cried and cried and cried. And then I was totally fine. And it was like a reset button. My mind was clear, my heart was light. I knew what had to be done, and soon my son was okay. So I think, like they say, the universe doesn't speak English, it speaks frequency. So I think, and that is what homeopathy and yoga are based on. It is based on the language of frequency. So I think when people criticize homeopathy for placebo effect, I always tell them that a mother's touch is also placebo only. There is no physical, chemical remedy in it, but it has tremendous power. So this I remember, and because I related to homeopathy and yoga that I'm very fond of, so I think that's why it stays with me. But it's a comforting thought, it's not something I want to get rid of. It's a good feeling. And I'm talking about 2005, so I was not very young, I was 40 then. Imagine a 40-year-old man going and lying down in mother's lap. It's quite crazy actually, but anyway, that's what happened. I would go home for lunch a couple of times a week because this is office, that is home. There's a 1-minute walk. And my father has always been a late Latif in the sense he never used to come to work before noon or something. So I used to wait for him to come. And then once or twice a week, I would go sit in a room with her and have lunch. And she was always aware because he would always take the work home in that sense and always tell her that this is what we argued about today. Every day was a new argument for a certain number of years. Not everything was very volatile, but something or the other was always going on. So then she would talk to me about that. And then there are times when I would just listen to her. There are times when I would walk out on her. And she was also in a very difficult situation because there is a husband and there is a son. And there is a company caught in between. And there is a competition that is not going to give you an extra day. So what is the role a mother can play? She was not a manager or a consultant or a professor or something. So she used to talk about it. Sometimes I was patient with it, sometimes I was not. But I must have done that for several years, maybe for about 10 years, I would say. Yeah, from about 2004, when she started slowing down, till 2013 when she passed away. So Dr. Rajan Sankaran, once he told me, he showed me a book. And he said, this is my favorite book. And it was called My Secret is Silence. Really, I found, of course, I am absolutely unable to implement this. I try very hard. I try at work, I try at home, I try with family, I try with friends, I try with myself. But to be silent is very, very hard, as we know. And it is not for nothing that people like Gandhiji used to be silent for periods of time. And this I saw remarkably in my mother, that when confronted with a difficult situation, she knew how to be silent. And silent not in a passive sense, in the most active sense possible. by absorbing whatever is that stress. It may be a domestic stress, it may be business stress, it may be something to do with health, something to do with family, whatever it was. She had this remarkable ability to just sit, be silent, and in her that presence, the stress used to eventually go away. She had this most unbelievable quality. Silence is not, I think, the end point, but unless you start with silence, you're able to be quiet, you're able to still the mind. How will you observe anything? How will you understand anything? We are all reacting, as Dr. Rajan is always telling me. I mean, he doesn't say for God's sake, but I think he means it. That don't react, respond. What is the difference between reacting and responding? It is the ability to take a pause, take a few breaths, be silent, maybe even for a day, on that topic, not that you should not talk for a day. Be quiet. And then what you will observe, understand, and what your response will be, I have seen with myself, it's totally different. I mean, I saw a wonderful video that my good friend, very close friend, like family, Abhinav Bindra recommended to me on meditation. It is by Rupert Spira. And I think it's a 54-minute video which is called something like Nothing Can Give Us Happiness. And it's very interesting because, it's all about the silence only, in the sense that what he says in that, what I remember now, he says fundamentally, happiness is a constant. He says as a child, if you get a toy, you are happy. When you grow up, you buy a house, you are happy. So that is a toy, this is a house. But his contention is that what you experience as happiness, that is the same. He said when you get 100 on 100 or you get a promotion, that happiness which you are experiencing is actually the same. So that is the first thing. That this happiness is a constant, it doesn't change. It's not that you are experiencing a qualitatively or quantitatively different happiness now than you were 50 years back. It's not like that. He says secondly, the happiness is like the blue sky. It is always there. Now, just because the clouds are there doesn't mean the sky is not there. It is you who are handing over your happiness to the clouds. You have to distinguish between the sky and the weather, is what he's saying. And where this was practically important for me is, and give you the simplest of examples, is in dealing with your domestic stuff. I think half the time we have domestic stuff only so that we can vent on them. And I realized in so many instances that when my staff or my driver or they're talking to me in certain way, doing something certain way, etc. If I just pause, if I let that silence happen, and I first reach inside of me and I say to myself, I am fundamentally a happy person. My state is happiness. Do I let this clutter that state? Do I let this cloud take away from the fact that there is a blue sky behind? If I come from this point of view, my response to the person is completely different. Then if I immediately react to what he says or does not say or does not. So this is the second thing I remember him saying. The third thing I remember him saying is that if you're still not convinced, think about things that make you unhappy. And ask yourself, is the situation really so unbearable? Forget about log kya kahenge and all that. You just ask yourself whether that situation, whatever it may be, money, love, health, possession, whatever is it really so unbearable? So how the problem is solved there. Now he says that even if you feel something is unbearable, it's nothing new he says, but I like the way he said it. He says, ask yourself, is it the situation which is unbearable? Or is it your resistance to the situation which is what is unbearable? It is because you are resisting that. And you are not able to at that time say to yourself that this will pass. Let me surrender to it for now. Let me reflect, let me think. There is always a solution. I mean, these kind of simple truths are abandoned at that time because you allow yourself to be sucked into the weather. So this is where the importance of silence or quietness or stillness or whatever, but it is not passive. It is very active. You have to very consciously make that effort within yourself to tell yourself not to react. And it's easy with the small stuff, but it's not easy at all. I mean, today, if you have a business environment which is very stressful, or if you have somebody who is not well, or some other stress in life, it becomes very difficult. But what is the other solution? There is no other solution. Abhinav used to tell me, I should tell him, yaar, tu kuch bolta hi nahi hai. I met him about 4 years ago. By coincidence, that's not important. But I went to visit him at his house. Then I found that I am spending most of my time with his parents. And he was, of course, practicing for Rio at that time. But whenever he's there also, he's silent, he's quiet. And I think now he's about 36 or so. So, great Indian tradition, shadi kab hogi types and all that. So as we got to know each other a little better, so all these kind of conversations used to take place. But he used to tell me, he used to say, whether it's in terms of making friends, going to a party, being social, or having conversations, etc. It's very difficult for me. Because my whole life has been only about being quiet, and quiet. And if you read his book, that one shot at glory or something, it's about winning the Olympic gold. He's written one book. It's an amazing book. It's a riveting book. You won't be able to put it down when you read that, And he describes in great detail, and of course he's told me many more stories at his shooting range, what goes into a person being so still that at 10 meters, you are going to shoot something which you and I cannot even see. And you have to shoot the middle of that damn thing. It's, I think, like some 2 millimeters or 3 millimeters, I don't know how much it is. It's like a really tiny dot. I, though with my eyes, can't see it also. And he can see it. And when he opens, I admire him because I cannot take a motorcycle apart and put it together. Joe can do it. That's why Joe is a great head of R&D. But Abhinav Bindra can take his gun apart to the last spring and put it back together. That's why I took my son there. I said, there's no better mentor for him than Abhinav. I found it in Paul Hoff and all that. But here's a world-class chap. He can take he used to tell us the Chinese pellets are the highest quality. He had done research on that. The pellet is so small. He had magnified them so big, and he used to see the size of the crack on the surface of the pellet, which you can't even feel, And he used to select them like that. This is what goes into being still and shooting the target. This makes the difference between the gold and the silver medal. He used to wear that stiff jacket, and I think he's written about it in his book also, how in a certain position when he used to shoot, he would cut a small slit in the jacket because that's the last bit of adjustment he needed for the last bit of stillness. How he would put a shim of 0.5 millimeter into one of the shoes because of the surface over there being in that way. What it goes into being quiet and withdrawing from the world. When at the time, if I have to go up on stage, so my pulse is normally 55. If I have to go up on stage, I can feel it is 75, their pulse goes to 150 because you are competing for your country over there. In that situation, because you can't control the heart which will beat in a certain way, but to be still and to shoot that target. So he says, now after spending 22 years of withdrawing, how do I suddenly mix with people? I don't know how to do it, he says. So this is also one kind of silence. So I found that all great people, whether it was Guruji Iyengar, who would be in one asana which I cannot do for 2 minutes, at the age of 75, 80, 85, he'll be in that asana for hours. How to still the mind, not feel that pain. We have all seen those monks who go to that minus 30 degrees and they sit with just their loincloth or whatever. I'm talking this kind of very, very powerful stillness, quietness, silence. So in a small way, my mother was able to exhibit, I feel. said, Guruji, please be gentle. I don't know what words I used, but I said that. So Guruji's thing was that he always said, on the mat, I will not spare you. Otherwise, he used to be, that's why I say, he used to be like a mother, Because the minute he saw you, he would give you a big smile. He would roar in laughter. He would slap your back really hard. He was very strong even that time. He was over 90, but he was very strong. He would sit erect. In the library, he was still writing his next book without glasses, at the age of 90. Erect in the library after lunch, when most of us have lunch and we are like all slid in our chair and all that. So his vitality was a different level. So he said to me, see, once you're on the mat, this is the first thing he said. I forget the person and I focus on the pain. So this was a good lesson to me that tomorrow anybody comes to me, I should, for anything, I should forget who's the person. Just focus on removing the pain, first thing. So he said, now let us start. I said, Guruji, I can't lie down without pain. How can I stand? He told me a very important thing. He said, the only problem in yoga is direction. He said, now you come and sit here. He took me near the window because in Iyengar yoga, everything is used as a prop. So that window grill is used as a prop. He told me, this is how you sit. Don't sit the way you are sitting like this. Your tailbone has to be at the back like this. Your spine has to be like this. Your shoulder has to be like this. He said, are you feeling pain now? I said, I'm not feeling any pain. He says, now you lift and turn in this fashion. Now you hold the grill like this. Now you twist. I never thought I can twist. I was able to twist. He said, do you have pain? I said, I don't have pain. So he said, remember, whether it is yoga, whether it is work, or whether it is life, the first problem is direction. If your direction is not right, everything will hurt you. If your direction is right, nothing will hurt you. You may get there late, but nothing will hurt you. I said, okay, very good. Then he made me do all those basic twisting and all to warm me up. Then he took me on the mat. He said, now you do Sirsasana, headstand. I said, Guruji, headstand, and there are other students, So I said that now headstand in this condition, impossible. He said, you know how to do headstand, no? Your headstand is very good. I said, yes, very good. He said, you do it. He made me do it and he said, be aware. The ear, the hip and the ankle has to be perfectly in line when you are upside down. And then on my left foot, which was the bad one, he hung a weight, I think about a 5 kilo weight, and he said, you push against it. I didn't know that time he has hung a weight. But if somebody had told me that that day I was going to do a headstand and have a weight hung on me and push against it, I would have said, impossible, I can't sit straight. There's no question. There was no pain. So I asked him again, I said, Guruji, how come there is no pain? He said, see, the most important thing in yoga, and he told me, it will also be in your work. Once your direction is correct, is alignment. This alignment of ear, hip and ankle, etc. You must ensure. In your work also, one department with the other, one person with the other, one function with the other, the whole supply chain. If you are all aligned in the same direction, which is the correct direction, there is no problem. Your problem is when you are doing yoga, you are doing it with ego. You want to show how much you can bend, how much you can twist, how much you can do this. In that you follow wrong direction, wrong alignment, just to impress people who are watching you. That is why you have a problem. So he showed me how to do that. And 2 hours he made me do yoga, finally put me in a shoulder stand, which was not only not painful, but it was, it felt so good. And he told me, see, this is all that you need to do in the pose is 3 things. First, you take a position. Then you find your center in that position. Whether you are standing with your legs spread, whether you are upside down on your shoulder. The center is a position in which you feel nothing. Again, we are back to silence. If you are constantly adjusting, feeling you are going to fall down, or there is a little more load on this side, that side, you keep doing the adjustment. You adjust till you feel nothing. That is your center. And he said, now from that center, you have to spread out your arms and legs. So even though you are standing on your shoulders, but you can splay your legs to the side, provided you are in your center, otherwise you will fall down. If you are not in center, if your CG is not established, you are going to fall down. So he taught me that whether it was in work or in life, you find your center. Whether it is as a motorcycle company or in your life, whatever center you want to find, never leave that center. Whatever you do, you want to make an electric Chetak, you make it from that center. You want to make a KTM, you make it from that center. If you lose that center, then it is like crossing a Lakshman Rekha and some Ravan will come and take you to some other place. So I did that. So 2 hours of yoga I did, which was beyond my comprehension because I was in pain even when lying down. At the end of 2 hours, I felt as if my body, which from head to toe was in pieces, had got welded into one piece. And I walked down effortlessly. I went to my car and I didn't realize that I have to turn sideways, sit down, then swing my leg. I just went in like a normal person and nothing happened. I was able to just sit in the car. And I realized, oh my goodness, I have sat in the car like a normal person. I drove home. I was overwhelmed with emotion. That how a man, just by his hands and manipulation and words and such a great worldwide guru has spent 2 hours alone with me without using any instruments, equipments, medicines, nothing. And what a profound effect it has had on my mind and body. Of course, by next morning, 60-70% of that benefit was lost. But I was still 30% better. Now I said, I'm going to go back. Now I didn't wait for a phone call. So I went back. So he saw me, he laughed, slapped my back and all. He said, I knew you will come. I said, Guruji, again, we have to do the whole. He said, now you know what is to be done. You go and do it by yourself. So I said, okay. And I said, now I'll do it. So I went very often. But I told him, I said, Guruji, my doctor wrote an email to me saying that once you are rested, we have to do pinhole surgery. And that is the only way to fix your back. And here you have fixed me 30% with just 2 hours of yoga. How can it be? And he told me a beautiful thing. He said, see, there are 2 schools of thought. And this was invaluable for my work. He said that they believe that function follows structure. If they fix your structure, you will start functioning correctly. I believe that structure follows function. If you start functioning slowly, step by step, in the correct way, correct direction, with alignment, with center of gravity, find your center, expand from all these things which I told you, if you do it, your functioning will become normal. Because he said to me exactly what years later Dr. B.M. Hegde said when he came. He said the mind is not in the brain. He said every cell is intelligent, every cell will adapt. It is not only your brain which has intelligence. But you must start functioning correctly and then your structure will correct itself. So this episode with yoga taught me so much about how we should go about our work, direction, alignment, center, expansion, growth, etc. etc. But I have come to realize that my ambition is actually to, I don't know is the correct expression, to become nothing. This is my ambition. Because that is the most difficult thing. It comes back to this silence only. Because I read somewhere once, J.D. Krishnamurti has said, the minute the person says, I want to become, then whatever it is, you are no longer free. And it's true. You are no longer free. So I'll tell you in a practical way what I mean. So for me, I just said that all matters of R&D etc. handled by Joe. So my colleague Joe looks after that. My colleague Pradeep looks after all engineering operations and all the businesses of marketing, sales etc. Rakesh is there. We have a head of finance, very fine gentleman called Soman. And I have 2 colleagues which help more on the administration area, I would say. Both are Ravis. So one is Ravi Kumar who helps me with my business development activities and Ravi Kiran who is head of HR. So the example I will illustrate with is this, that I used to observe, see people like Narayan Murthy, my father, Ratan Tata and all, they are more or less same age. My father, Ratan Tata, were in class also together. So since the time they were 50, 55, 60 and all, they used to say that, at 60 we should retire, the young crop should come up and all those kind of things. And some people like Mr. Murthy have retired, I think he has retired. But most others conveniently made it 65. Then they made it 70, so on and so forth. So I realized that people don't want to let go actually. They always want to become something more, or they think they can become something more. So this question came to my mind also. I remember I was speaking at the same forum as Sunil Mittal of Bharti. And I think he was about 48 at that time. And he said that I want to retire when I'm 50 and I have made it such that the succession planning is there and all those things. So I used to try to look for the answer to this question. That when will I retire? That I can stop becoming somebody and enjoy my life. So when there is nobody, then I go to Dr. Rajan only. So I told him, Dr. Rajan, now I have a question for you at the end of all my health issues. What? So I told him this whole story. Now please tell me the answer. So Dr. Rajan is like one instant noodle, he knows the answer to everything. He did not take even 1 second. He said, in life, the only thing we need to retire is our ego. That's all. So there is no need to answer this question, when will you retire? In the same way, so whenever anybody asks me, when will you retire? I said, I have to only retire my ego, which I am not at all successful in doing. So I will keep trying to retire my ego. That is all I have to keep doing. As far as work is concerned, I told my colleagues long time back, long time means a few years back, that look, I have been here 30 years. So instinctively, intuitively, I know many things which all of you don't know. Because some of you have been here even longer than me, but you have not had the exposure I had. Some of you have been here only 10 years or 5 years or 2 years, etc. So I have that unfair advantage, let's say. And I have some strength in some areas. But 90% of what you all do, I can't do. So there is no point my coming here every day and sitting on your head. Because if I come, then I have to do something. That means I have to call people, I have to meet them, I have to ask questions, I have to conduct reviews, I have to give instructions, which is all a very waste of time actually. So we work 5 days a week now. I can say that I come to office not more than 2 days a week. And my goal is to make it zero. So when you say, what do you want to become? My goal is zero only. Yamaguchi-san taught us, the goal of all TPM is zero. Zero defect, zero breakdown, zero rejection. And in my case, zero need for me in the office. But it doesn't mean that I am retired, because I get paid a very big salary. So there is no question of retiring and giving up that salary. But am I going to come to work, put my car on the road, contribute to greenhouse emission, cause congestion, make my presence felt, waste people's time just because I am the MD who is supposed to know everything? I am not going to do that either. I sit at home in my garden and I used to watch my grandfather doing this. Maybe my father will say that he has a selective memory, he conveniently picks up what he wants. But my grandfather, I think, was a great entrepreneur. I think if you talk to people, they will tell you, my father is a manager. My grandfather was the entrepreneur who could risk putting money into new things. Like this company was started by him, not by my father. And my memory of him is a wooden bed with an incline that he used to sit on in the sun and get an oil massage and conduct his work from there. So I also try to do that. Sit in the garden, I sit with my dogs. Today we know that work is not a geography. With your phone you can work from anywhere, whether it's a call, a message, a WhatsApp, email, whatever it is, even on the video, etc. You can do it. So my goal last few years is to intervene the least, to let people do their work. Of course, I have my own way of knowing what is happening, of focusing on priorities and all that. But to do less and less, because I will finish by telling you 2 very nice quotes which people have told me. So one is this fellow whose name I cannot pronounce, who says, less and less is done until non-action is achieved. When nothing is done, nothing is left undone. In the yoga asana, it is like that only. You have to do, when you perfect your forward bend and you are touching your head to your knees, the struggle has to stop. You have to give in, you have to exhale, you have to be humble, and then only you will touch the head to the knee. An egoistic person can never touch his head to the knees. It is impossible. So you have to do less, less, less till non-action is achieved. When nothing is done, nothing is left undone. Anyway, this is too complicated. But the simple version was told to me by Shahrukh. We were sitting in his house one day and chatting. And I saw a photograph which looked like a black and white photograph of his father. So of him. So I said, "Arey, who has done this photo of you?" He said, "That is my father." I said, "Oh, it looks exactly like you." He said, "No, that's my father." And he has told many stories about his father at various forums. So he told me also some stories. In that he told me that one of the greatest lessons his father taught him was, जो कुछ नहीं करते, वो कमाल करते हैं. And I never understood it. I thought as usual Mr. Bollywood is being smart, over smart, slapstick and all those things. But then I realized that those who can make it such that the things happen and they themselves look like they are doing nothing. So there was somebody said no, that the leader is, I don't know what the words were, but the leader is the one whose people say, we did it ourselves. He doesn't stand there and I am holding the flag, I am marching from the front, I am leading. This whole Western egoistic leadership concept, I am leading from the front and setting example, is that it can all be done, but it can be done in a very silent, quiet, still way. So then I understood what he is saying, कि जो कुछ नहीं करते वो कमाल करते हैं.
Thank you. So that was such a nice talk, a different topic and a lot of messages there. So I think it's important to have that center of gravity, that alignment, and the quotes which he mentioned were very nice. So thank you, Rajiv, for that nice talk. With this, we come to the end of today's program, and I request our president, Professor Ajit Shinde, to please give the closing comments. Shinde, sir.
Okay. Good evening, friends. I would like to thank you all for your participation in this grand webinar on advanced knee arthroplasty under MOA Masterclass series. We are fortunate to have a national-wide dignitaries in field of knee arthroplasty for today's webinar. Session was really fantastic. We started with decoding the alignment of Conundrum by Dr. Suryanarayan from Chennai, followed by understanding instability in TKR by Dr. Ashok Rajgopal Delhi, and then how to use and increase constraint in primary TKR by Dr. Harish Bhende from Mumbai, and lastly, implant option in revision TKR by Dr. Manuj Wadhwa from Mohali. I am sure all the lectures enlighten us in this difficult topic. And at the end, the special talk on silence, happiness, and the quest to become nothing, a different approach for life by Mr. Rajiv Bajaj, MD, Bajaj Auto, was again wonderful, impressive, and mind-blowing. Friends, as a president of MOA and organizing chairman, I was supposed to attend IOAEC, which was at 5 p.m. exactly at that our program, and I could not attend the program from very beginning. But I'm happy to inform you that finally the IOCON 2021 is going to be held physically at Goa by Maharashtra chapter, where all the district chapters and city clubs are involved. I request everyone to cooperate wholeheartedly to make the conference grand success. With this, I thank everyone, those who are listeners, those who are teachers and faculty, and special thanks to Parag Sancheti, who has given us the wonderful faculties and this non-academic talk. I am also thankful to OrthoTV and Shyam. Thank you very much.
Thank you, sir. It was indeed a nice program. Thanks for joining and thanks for your lovely idea of starting this MOA Masterclass on Sundays. With this, we come to an end. Special thanks to all the faculties, Dr. Harish Bhende, Ashok, Raj Gopal, sir, Dr. Manuj, Wadhwa, and Dr. Suryanarayan. It was really nice. The talks were wonderful. I also want to especially thank our MMC observer, Dr. Nitin Bhagali. He could not join, but as all of you know, we have 4 MMC points for these 4 master class arthroplasty sessions. The next 2 ones are going to be on hip replacement, which will be done by Dr. Sahil Sanghvi as well as Dr. Mahesh Kulkarni. So that will be the 22nd and 29th of August to come. So that will be hip topics. So please join. You will get 4 points if you've attended all the 4 Sundays. And MMC credit points are important now. With this, lastly, I want to thank Dr. Ashok Shyam also for screening this on OrthoTV. As all of you know, it has a big reach. There are more than 30,000 orthopedic surgeons who can potentially see this program. So thank you so much, Ashok. You've been wonderful, and I think you've added a new dimension in today's era by introducing, the OrthoTV platform, which is so useful. We can visit the talks again. If you go to the OrthoTV website, you will see all the talks which are there, and it's a wonderful resource. So, Dr. Ashok, we are really thankful to you and for partnering with the MOA Masterclass. And I'm sure now the IOACon is coming, and we will require more your help now for the IOCon, and which will be held in Goa from 21st to 25th December, as just announced by our president. With this, thank you, and on behalf of the MOA President, Dr. Ajit Shinde, Secretary, Dr. Narayan, Karne, and the Executive Committee, I thank all the delegates who joined today and also the entire faculty. Thank you. Happy Independence Day. Good night.
Good night.
Dr. Parag and Dr. Can I speak?
Yes, sir. Ashok.
Dr. Parag and Ashok, now there is a more responsibility for us to arrange a curtain riser programs for IOCon 2021. Then both of you have to give the new ideas for the publicizing our conference.
Yes.